All right, everybody. Welcome to our 2024 Partnership Summit. It's really wonderful to see so many familiar faces and some new friends to welcome into the CEO Roundtable and Project DataSphere family. I'm John McDonough. I'm the president of Project DataSphere, and I'm really happy and to have this opportunity to get to know everyone here better and to build and continue to move forward with these partnerships that we've intentionally been creating and developing over the past few years. I have a wonderful opportunity now to introduce our new CEO, Sean Khozin. He's unable to join us today in person, so he has a recorded message that we'll be playing here in a second. Sean joins us after, well, he's had a tremendous career. He was at the FDA for several years as part of the Oncology Center of Excellence and their data science initiatives. He was at J&J and was the founding CEO of ASCO's Cancer Link program. So among many other things that he has done. He's also a talented musician and composer, and so some of the interstitial music, I'm told, will be some of his compositions. So please enjoy the message from Sean. Thank you.
Hi, everyone. I'm Sean Khozin, the newly appointed CEO of the CEO Roundtable on Cancer. Unfortunately, I'm not able to join you in person today, but I'm with you in spirit and fully committed to the important discussions you're having at the summit. I step into this role fully aware of the immense responsibility it carries in advancing a mission that touches many lives as we stand at the forefront of one of humanity's most critical challenges, the fight against cancer. The themes of this summit are a great reminder of the core mission that unites us all, ensuring that every person has the opportunity to lead their healthiest life. I know this is not just an aspiration for us, but a necessity as it demands that we continue to address social determinants of health head-on, dismantle disparities, and guarantee equal access to healthcare resources for all. In our quest for representation in cancer clinical trials, our collective efforts are also very vital. The diversity of our nation and our patient populations must be appropriately reflected in our clinical trials to truly enhance personalized treatment decisions at the point of routine care. Through increased access, choice, and education, I believe we're making this a reality, ensuring that our scientific advances benefit everyone. My appointment comes at a truly transformative moment in the biomedical enterprise as we turn the page to a new chapter brimming with possibilities. I'm very excited to be your partner along the journey forward, embracing innovative approaches and forging new pathways with you in cancer research and patient care. The Roundtable's legacy is undoubtedly rich with many achievements and milestones, yet the road ahead calls for even greater strides. With the convergence of advanced analytics, including AI and machine learning, and our collective expertise, we are uniquely positioned today to accelerate progress in the field. Your work, the partnerships you nurture, the knowledge you share are the bedrock on which we'll continue to build a future where cancer is no longer a formidable foe, but a challenge we're equipped to overcome. I think ultimately it's the synergies of our collective efforts that will define the impact we can make. It's a true honor to join this community of visionaries and change makers. And I thank you for your unwavering commitment and look forward to the shared successes that await us all. I hope you enjoy the summit as we all embrace the promises that lie ahead. Thank you.
All right, and now I will get out of the way. We're really just tremendously grateful to SAS and their sponsorship and support of our organization over the years. Gail Stevens, the head of the Life Sciences franchise, is going to be the one who introduces the first session. Thank you.
Good afternoon. It's good to see all of you here in person. And in the spirit of this being a partner summit, I just wanted to say, when great things happen when partners come together. At SAS, when we decide to partner with organizations, we first kind of look at the potential partnership and decide whether we'd be better together. And once we're convinced that we would be better together, we go down that path of partnering. And we do make a difference when we're together. This is a whole room full of leaders. The biggest challenge, I think, in partnering is, and this is a challenge in leadership as well, is just you have to learn how to listen. You have to be a good listener in order to be a good leader. So I really encourage all of you during the course of this summit to really listen to one another. When you have problems that you face, everybody looks at them through a different lens. So all of you will be looking at them through a different lens. And I think once you guys learn about each other and how everybody wants to approach the problems, we're going to make a huge difference. On behalf of SAS, I welcome you to our campus. And anything that you need from any of us at SAS, you can grab me or anybody else at SAS, and we're always happy to help you. I'm glad that we are able to host you, and I look forward to many more events with this team or this group. But my first pleasure is to be able to introduce the panel, our first panel. So I'd like to welcome our panel onto the stage. Okay, so we have as our moderator today, Jude Yang, who's the Executive Director Representation and Clinical Research at Amgen. We also have panelist Cherry Beasley, who was the Chief Nursing Officer, Endowed Professor of Rural and Minority Health at UNC Pembroke. We have Janine Calkins, Vice President of Oncology Clinical Project Management, Clinical Trial Diversity and Patient Engagement at Bayer. And we have Tim Gable, President and CEO of RTI. Thank you very much.
Thank you. Good morning, or good afternoon at this point in time. I'm from California, so it's still morning in Texas. and by the way, thank you to North Carolina for the rain. I brought the storm with me. When I came first, the weather was warm, and I'm like, okay, this is a transition, but however, no, I brought the storm. So we're going to have an exciting panel today, but first I want to say thank you to Sean, the new CEO, and also to the CEO Roundtable team for organizing this, and most importantly, SAS as well for hosting us. Every time I come here, it's really great to reconnect with friends, with people we work with virtually, but most importantly, making lots of new connections. A lot has already started. The few sessions that have happened this morning are so exciting. And Sean actually said it in his opening remarks about the panel, the topic of the panel we're going to be addressing today, which is the social determinants of health. But let me go back. So before I start, I actually have a few opening remarks. So I'm Jude Yang, as it shows there on my title, with Amgen, pharmaceutical company. We have a simple mission at Amgen to serve patients. And we do that with a focus on developing, or first discovering, developing, and then delivering medicines for very hard to treat conditions, and ensuring that these medicines make it for the right patient, most importantly, at the right time. What we've learned, however, that it takes more than just these solutions we're developing in terms of therapies to actually alleviate the burden of disease. We do all we can, have the solution packaged in a vial, in a tablet, in a capsule, in whatever form. However, there is significant disparities in health outcomes, and it continues. Right? So then, with the same courage we used to develop these medicines, we're also now moving forward to using that same courage to partner in bold solutions, actually as well, to address these barriers to really improve health outcomes. And one of those barriers, amongst many, as we are aware, is the social determinants of health, right? I think before I go forward, I want to say my heart as a pharmacist by training, I have a different way of looking at it. We're now at this point, what I see is the social factors that are important to health is as essential to health as the periodic table of elements is essential to sciences, and in this case, biomedical sciences. So it's actually really elemental that we now address these as well. So today I'm joined by an esteemed panel of experts across the industry, academia, and also nonprofit sector that touches both government also and the private sector. So today we would focus on solutions. Why, I've even heard it in earlier sessions today, the issues of social determinants of health have been studied and are continue to be studied. However, the efforts to address are not matching. So today we're focusing on a solutions-oriented approach, today's dialogue. That will be our focus. And we'll have time, as we discussed, to open as well to interact with the audience for a question and answer session. And if we have time again, we can come back to the panel for closing remarks.
Okay.
So that said, I will start with you, Cherry, being from academia.
Okay, thank you. So I'm on the panel not representing academia, but particularly HMSIs, historically minority-serving universities, because we know that education is the great equalizer, but also how do we really embrace universities that have a lot of experience working with educational inequities, and then maybe some economic inequities, now focusing on the whole piece of health inequities. And I'm going to begin by saying one of the major ways we do this as HMSIs, and I'll use UNC Pembroke as an example, is that we actually have our student population, our staff, our faculty are endemic in the cultures in which we are trying to reach, which have been found to be very hard to reach for research, particularly clinical trials. So just to give you an idea, UNC Pembroke is the third oldest academic institution in the state of North Carolina. However, we are the most culturally diverse campus. You may know that we're a historically American Indian serving campus established by American Indians for American Indians in 1887. We have no majority population on our campus. We have a good mixture of white, Caucasian, African Americans, American Indians, Hispanic, people who are two or more races. The same thing is true with our faculty and staff. But when I look and then how do I deal with this with the social determinants of health, they are all mixing together, so they live this every day. At UNC Pembroke, 49% of our undergraduate student body are Pell eligible. We also have 30% of our student body are first-generation college. Many of them are first-generation high school graduates, as well as then going on to college. And then we have 52% of our campus, our undergraduate campus, are from high-impact counties here in North Carolina, meaning counties that have been recognized as being economically and educationally distressed. So when I say that we're endemic, we are actually who we're trying to reach. And one of the things that we've learned here at UNC Pembroke is that we first take care of the needs of our student body, and that's because they bring their housing issues, they bring their transportation issues, they bring their food insecurity issues to us. And so we have food and clothes closets, we have food vouchers and housing vouchers. We actually have to help students with transportation. When I was a faculty member, it wasn't unusual for somebody to say, I can't come to class, I don't have a ride today. And then how then do we address that and keep that student moving towards a graduation rate? One of the other things that we actually do, as well as working with the students and recognizing them and hearing their voices, because they tell us in forums, and when we have different activities on campus, our living learning communities, they tell us what their needs are. And since they represent the population, they tell us what the population's needs are. We also then incorporate a lot of those things into our curricula. We have curricula that whether it's in the classroom or in extracurricular activities that our students do. Right now we have ICC graduation requirement. Most of the HBCUs have African American graduation requirement. So they study their culture. And it's important for the Indian student, American Indian student, it's important for the ally student, it's important for all the students to have interactions. And the other thing we're finding is that having interdisciplinary classes really helps students understand each other's needs and understand each other's worldview. And so then that allows us to build trust with the community, with our student population, and then everybody else. So I think we have a very specific role that we can play. Not only, we'll talk later about how do we develop the workforce for tomorrow for researchers, but HMSIs are very critical in this way.
So maybe, Cherry, before I move on from you, one more question again.
Okay.
How can these, the things you're doing, your institution is doing to address the social determinants, how can that be applied to address the health equity issues?
So we have a very large mental health and student health service on our campus because we do realize those students bring those things to them, and if we don't address them, then they'll drop out of school. So we look at what can we do, and then what service do we need to offer the students, and then because they live in the community, most of them go back to their communities at night, a large percent, or on the weekends. They take that information with them. So we've learned that even educating the student population gets the information out into the community. Even our TED Talks our TED Talk session last spring was on, we used social determinants of health around that and had people address those things when we were getting ready for our TED Talks. And when we actually do go out with our mobile units, we actually have a lot of people go out and have interdisciplinary activities so that we can then mimic what needs to be done in their research and in their classes. So we want to give them an experience of the classroom, extracurricular activities, meeting their needs, how can they bring in things from their community, and then that helps us build trust. Because a lot of people come from our things and say, we don't want any more research. We've been researched to death. We haven't seen anything from it. So now why would we do that? And so even when we talk about developing the next generation, having that experience themselves, participating in a research study themselves, really helps.
Well, thank you. I think thanks for staying on that solutions-oriented approach and not overburdening these communities again by over-surveying them. Right. So maybe I'll switch then to you, Tim, if that's okay. Tim, you're part of RTI, and maybe I'll call on you to first briefly talk about RTI, just to level set the audience. But most importantly, what I'm really excited to hear is implementation science. That's a phrase that's now sort of developing in the life sciences industry or life sciences ecosystem, because we develop strategies, we talk, but then how does that translate into action and results? So I see where implementation science actually has a key piece. And your institution is at that intersection between the government and the private sector, so a key player in the ecosystem. So maybe can you take us through how you're leveraging implementation science with your federal clients and also your government clients and also the private sector?
Yeah, happy to do that, Jude. First of all, let me just say what a pleasure it is to be up on this stage with such experts. Just to quickly level set, as you suggested, RTI International is just down the road here. We're a 65-year-old nonprofit research institute. When the Research Triangle Park was created, where we're all sitting, the wisdom of the leaders of the state at that time created an anchor tenant, and that was RTI. And we were created with a partnership mandate, really to partner with specifically the Triangle universities and help stem a brain drain problem that was going on at the time. And so, of course, 65 years on, you've got fabulous companies like SAS and this burgeoning life sciences industry that we have, and we're so blessed to have that. At RTI, our mission statement is to improve the human condition by turning knowledge into practice. And when you think about this phrase, implementation science, and it may or may not be familiar to some of you, but what is that? What do we mean by that? Implementation science is really the study of the methods, of the processes, of the approaches where you take research findings and put it into action. Really take what we know and turn it into what we do. And I think all of us in the room know that, especially when we think about the issues around social determinants and the issues around underrepresented populations, particularly in clinical trials and so forth, that's a gap. That's a problem. And so in the sort of academic research space, this is not really a new concept. 10 years ago, we came into partnership with UNC Chapel Hill and created a consortium for implementation science. We've had a lot of government-funded work from the NIH, from the NCI, from NIDA, various, so it's not something that's unique to health. You know, when you think about driving cultural change, the importance of understanding the context and the local boots on the ground reality, just like you were talking about, Sherry. The local context matters. But what is the science behind trying to understand that and how to think about that? And so we've worked for a long time in this notion of trying to turn knowledge into practice. And we've been active in this space, and the NIH and other government agencies have been as well. Increasingly, what we're seeing is the opportunity. We have about a 500-person group that specializes in working with pharma, life sciences, biotech sector. And we're seeing more and more opportunity to bring some of those principles of implementation science and work with our life sciences partners as well. And an example that I was given by our team to maybe mention as an example, great new treatment, PrEP treatment for HIV. It's there. It's understanding how to convince, young women, African-American women targeted specifically, to trust. And how do you create trust in the community? And how do you, even if we know it works, how do you bridge that gap for, everywhere from the providers, from the payers, but especially from those who stand to benefit from a new treatment? And so part of what we're excited about, and again, very honored to be here to talk about partnership in this space, is how do we work together? Academia, government, policymakers, research institutes, the industry certainly, to understand, because the more we sort of begin with the end in mind, in other words, don't wait until the drug's not being adopted and say, what are we going to do about this? Let's start understanding why, but build into the design and the life cycle of the clinical trials process and so forth, some anticipation of getting to that point to ensure not just efficacy, not just safety, but adoption and ultimately benefiting people.
Absolutely. So I think maybe that partnership is key. You mentioned some opportunities. Can you maybe elaborate how the partnership with academia, industry, government, how can that help? How can implementation science help address health equity?
Well, I think it starts from understanding the data that demonstrates that there is inequity, right? And so certainly government funders that collect population health data, that make that data available, that's a role that sector can play. And certainly at a policy setting level, we're seeing right now more and more emphasis from our federal government clients on ensuring that health equity is baked into a study design or whatever. But I think you have to come at it from a pragmatic economic value standpoint too. For industry, it's and even for a place like RTI, it's not about altruism and like moral correctness. It's how do you make the economic logic model fit together? I think academia has a great role to play in terms of basic research, in terms of fundamental findings and so forth. We're very applied. We try to play a role and be in the lane of whether it's demonstration projects, whether it's taking things to scale. And then I think the industry can be both a funder of opportunities, but also a beneficiary of what stands to be gained. And ultimately, the people of the world, not just the United States, the people of the world who have either not enough access or not enough understanding of how they might benefit are the winners in that.
May I give an example of what he's talking about?
Absolutely.
That we did with NC Collaboratory. Pembroke has done that. And in the midst of COVID, and we know that a large percentage of African American and our American Indian and poor rural population chose not to get the vaccine, didn't want anything to do with it. But we were able to get a grant through NC Collaboratory where we actually gave a service, went into the community, gave a service, and did research at the same time. And we were able to surpass our goals because that allowed people then trusted. You provided the monies that we needed, we didn't have as a university. But then we were able to say, well, how can we work together with this whole idea of science, implementation science?
Excellent.
And collected some good data for you. Thank you.
Very good.
Wow. I have to react to that, and then
Okay.
I'll come back again to you, Sherry.
Okay.
I'm not skipping you on purpose, Jenny.
I'll be quiet.
So no, truly, you made something I wanted to react to. You made a point there, Tim. It's not just a moral or a social justice thing. Not for Adamgen, we don't believe it's even just a scientific thing. It's actually a business thing to do, right? It's important that
Good business.
our mission is to serve patients. The patients is part of the business model. So when we look at things from this perspective, these are eventual clients from a business standpoint. You actually see some push to drive for that investment. The challenge is how can teams, industry, other partners as well look at this differently from the traditional return on investment route, right? Which is we all function in an ecosystem financially that is dependent on quarterly and annual. So when you look at the long-term impact of investment, when do you really get a return? That's the challenge I think that we have to start advocating more and more, to start having our boardrooms maybe to be thinking about how do we carve out investments. So really wanted to point that out because it's important. As we go for funding or to support for partnership, we have to run that up the chain. And when it gets to certain rooms, we have to really try to defend and not expect the return on investment as usual. And one key thing as well that we do say internally as well, we say we move at the speed of trust. Right? So moving at the speed of trust, that's literally our motto as we tackle this issue of health equity, social determinants of health. We have to move at that speed and then try to get our leaders and our funders as well to be with us. So maybe, Cherry, I'll come back again to you as I mentioned.
Okay.
The historically minority-serving institutions, honestly, they bear a significant burden in addressing these issues for the most part. And now, can you tell us then maybe what additional support may be needed to be a partner in health to make sure that you were there is no burnout, the staff is no burnout? Can you elaborate on that?
Yeah, and can I tell you, I wore my brooch today to show everybody that we're barely hanging on. Because it is. There is HMSIs are some of the least funded, underfunded institutions in our system and in our state. Even faculty salaries, staff salaries. So those are critical, but they also have a higher teaching workload. And so if I'm going to have faculty who can role model and work with students who can get experience, the institution needs support for resources, maybe some infrastructure, but as well as some assistance in going through the process. Students need assistance because, as I mentioned before, we have, I don't know if I gave you the statistic, but 69% of our students at UNC Pembroke go full-time. Everybody else is working, going to school part-time, and mainly it's because of work. They need to work to put food on the table. So if we had some opportunities where they were getting experience in research and also staying on campus to being campus-focused, then that would actually be a big help. So looking at how do we fund programs where we ask the faculty what is needed, the students, and what do your students need so that they can engage and be trusting of this whole process, but also not have to make a decision between helping put food on the table at home or babysitting, doing child care things at home, and going to schools, because we want to be able to have that holistic approach to them. But I also want to give you an example. UNC Pembroke started about this time last year, maybe a little before then, working with Blue Cross and Blue Shield. Bayer, not Blue Cross and Blue Shield. We work with them on another project. Bayer and Duke to try to address how do we look at clinical trials. And the first thing we did was pull a group of people together from the campus, from the community. They represented providers, agencies, the tribe, different people, and said, what do you think? What's needed? And so being able to have some opportunities to even start at that ground level is important, because people themselves are the bearers of knowledge. They're the owners of knowledge. And until we actually say that and recognize it and believe in it, then we are not going to make the good business model, I think, is for you. But actually, then you've got to invest in these schools. We do not have the extra cash. We do not have where faculty can take a leave for a good long period of time to develop some of these things. So people are doing it hanging on by the skin of their teeth, but they really want to do it. They're focusing important for them to do this work? And then how do we role model that for our students? So even with some financial assistance, some infrastructure assistance, some student, maybe even sharing a senior researcher with the university so that they're there for a year to help us role model and get those things started. Those are things that we need.
Great. I think I would come back to you maybe on the workforce piece.
Okay.
But again, I have to go now to Janine because you called Bear. So.
Well,
You called me out, and actually I was going to bring the point to you as well.
okay.
So Janine, maybe Bear has they made a commitment, health for all or health for all, right? So I think, can you maybe expand how Bayer has demonstrated that commitment in terms of how it addresses the social determinants of health, and if possible, talk about how that could be expanded as well or replicated or maybe to have a broader impact?
Definitely. And as I close, I'll refer right back to Sherry because she's in my dialogue here. So I guess the first thing I want to talk about is the fact that the first step to address the social determinants is to remove the barriers. You'll hear a little bit more about that in the next panel discussion, the ACE, Access, Choice, and Education. But I wanted to address at least a couple of examples that bear what we've done. So one example of access is we were looking at patients that need transportation in order to reduce their out-of-pocket expenses. We initiated a global sort of mapping project. We looked at all these different countries, what the participant programs expected. We understand that the fact that clinical trials are getting increasingly more complex, and therefore there's an urgent need to make sure that the patients are compensated for their time, their effort, and any kind of burden. So we hosted some calls with very local sites. We asked them to challenge their ethics and health authority, and we asked them to put plans in place on how they could get this feedback and these patient contributions reimbursed. Some countries were really surprised with the feedback. They put these payment plans in front of them, and they were shocked that they actually agreed to them. This word spread out, and then 4 other industry people had stepped forward and said, let's start other projects to look at this. So SCRS did a participant payment work stream. The Diversity Convergence Project took place, and then the fair payment strategies followed by longevity's best practice. So this is like a cascading domino effect of starting one project, sharing information about the success of it, that really just sort of changed a number of things. In the very end, it actually even helped the National Academy's report to recommend a way to improve their diversity. They developed explicit guidelines. They gave guidance to the local IRBs on what equitable compensation would be allowed for participants as well as caregivers. That included lost wages for lower socioeconomic patients. So this has changed a shift in payment approaches, policies. So that was one of the examples. And all this helped to reduce the financial barriers for patients in clinical trials. The next example, and you'll hear a little bit more about this the next time, had to do with education. Last fall, Bayer had worked together with Zero Prostate Cancer, and we did a run in San Antonio, Texas. After the run, there was like a brief panel section. It was all about prostate health. PSA testing vouchers were passed out. A lot of information was shared about resources that were available to patients, such as the Academy for Oncology Nurse and Patient Navigators, Emily Gentry, Say Yes to Hope. All of this was aimed at patients, their caregivers. They had an open forum to be able to ask questions, share their concerns, and it was all in the community setting. To the point that was made earlier, helped to build trust. And I'm sure Adrella will talk a little bit more about this a little bit in her next, in the next panel session. And my last example is about choice. And I guess you'll hear a little bit more about this in the next session as well. But we've seen a lot of, I guess it's the point that Tim made. You see a lot of people doing something that's successful, and how do we replicate it? We know that there's this hub and spokes model. They've been doing this at large institutions like Memorial Sloan Kettering, at Columbia. They we're working with Duke, and that will lead you back to
PNC Pembroke.
with PNC Pembroke and yourself. So there's a lot of site capacity building. We're all doing it in a silo. And how can we take that, share, and then replicate it in a larger scale?
No, that's really important. I think as we work on programs, it's really important to come together because there's a certain investment in operations that is probably if efforts are put together, there will be less of that where there's more funds going to actual impact, action that leads to impact. So certainly, why is Amgen not on that list of your partners' opinion? I was listening intently.
You're coming. You don't know, but the invite's in your email right now.
Great. We certainly like to explore that. And then it's actually interesting because that led to work. You mentioned that the institutional review boards or the IRBs could then look at it and say, it's okay to compensate and to compensate at this level. That's a key piece we tend to forget sometimes.
Exactly.
When we design the trials, we go to the FDA to approve that we run the trials. But you can't run the trials without the institutional review board approving you to run that trial. But this institutional review board is made of people from the institution and community members
Right.
who may not really, they can stop your efforts because they're not well informed. So I'm really glad that led to that guidance. It's really touching the ecosystem. So maybe I'll go back again to you, Tim, one more time. Maybe talk about moving from implementation science now to cancer research. Maybe can you talk about how RTI is working with government and academia to advance cancer research and what type of efforts are also potentially could help towards health equity?
Yeah, I would love to do that. I want to start with what won't sound like I'm answering your question, but I don't want to lose the opportunity to talk about, I think, one of the things that we're most proud about at RTI that we've done. As a nonprofit, we don't have shareholders beating down our door for ROI. The profits that we earn on our contracts get reinvested back into our organization. And so we stood up a couple of years ago, and I'm proud that Stephanie's in the room today, our leader of a group that we call the Transformative Research Unit for Equity. And what we're trying to, and this starts to get at your point as we think about our government funders, whether we're working with NIDA or NCI or whoever, thinking about how do you bring things to scale? And the vision of our team that created and envisioned TRUE, as we call it, the Transformative Research Unit for Equity, really imagined how do we operate at a system level? How do we bring an equity lens to all that we're doing? The point you made earlier about the social determinants. I mean, yes, we can address a health issue, but if somebody doesn't have transportation to get to the doctor or can't be compensated because the IRB thinks that you're getting into the territory of coercion in paying people to participate in studies, whatever, how do we operate at the system level? And so I think one of the things that we try to bring to the table with our government funders, and particularly in cancer and health research generally, is that notion of systems thinking and understanding that it's not just the narrow lane, but the broader perspective in terms of which this will work. And we have a lot of staff that work on economic models. And so understanding not just the cost benefit of a new treatment that's coming out, but then trying to overlay it with that lens of equity, overlay it with that perspective of implementation science as well. And so we're not basic research labs for the most part. We do have some, and we have funding that are working on new compounds and molecules and so forth. But mostly, I think we're in that space of, and we don't carry out clinical trials. We do, though, have a lot of data coordinating center type projects where clinical sites around a particular topic all pool data. We manage the data, we set the statistical design of those studies, and really try to ensure that all parties, all partners, sort of as you were saying, are bringing the best of what's happening together. And so that's sort of a take on kind of how we get involved in that space.
Great, thank you for elaborating on that. I think I would also want to allow time for us to interact as the panel. If you hear anything you want to ask a question or a follow-up question, please feel free. But I'll go to you, Cherry, before I open up to the panelists to ask questions to other panelists and then also to the audience. So I think, Sherry, UNCP, or University of North Carolina, Pembroke, is the only historically American Indian serving institution in North Carolina. Now, is there something that UNCP is doing that could be replicated or that others could learn from and expand into other communities of underrepresented people?
Yes, I think so. And what I would like to talk about is we mentioned some things that were changing in the 70s with implementation science. Different American Indian groups, indigenous populations and indigenous people are located in every country of the world, every continent. So I think this is agreeable. We started including something called indigenous pedagogy in our classes and in our work, and now we're working with the Lumbee tribe right now to develop what their pedagogy, what their research pedagogy indigenous framework would look like. And so, but most of them, when you read things about that, there's some very specific things that are always included, and we found that they help us when we do our research at Pembroke. And that is what we call the 4 R's. The 4 R's are respect. You've got to respect the people you're dealing with. They're the owners of the data. And if you don't respect them and their traditions and what they're telling you, if you look like it's a jaundiced eye, you're not going to get anywhere. Okay. The other thing is relevance. Is this relevant to the people being studied? Lots of times we have people write in with their research project that they want to do, and with Pembroke we ask the question, how is this meeting the mission of UNC Pembroke? It's part of our strategic plan, even in dwelling with our community. So we look at relevance and then reciprocity. With reciprocity, are you giving the information back and forth in the community? Are you really sharing what you're learning and let the community respond? But then also, we have, say in the Lumbee tribe, it's the anthropologist wanting to write another paper on the Lumbees. We're not interested in that. But what we are interested in is having a discussion of how we can improve our ways of living and our health. And then finally, the last R that's in the literature anyway is responsibility. Are researchers responsible? Are we responsible in our classrooms, in our service learning projects, in everything we're doing? Are we responsible for the data that people share us with? Do we come back when they say, this is our plan that we're going to do? We don't deviate from that research plan unless we've come back to them. And that's an important piece. The other thing that we use a lot and talk about a lot at Pembroke is identity. How do people define themselves? What is the questions that they want answered? And so natural resources are very important with us, dealing with the things in the land and the rivers and stuff. So identity includes your relationships to both individuals as well as metaphysical relationships, as well as natural science relationships, natural resources. So how do we use that? I think if we think about that as our research model in addressing equity and respecting all people, not just indigenous people with those concerns, we're going to go far.
Thank you, Cherry. I think I firsthand experienced that back in my prior role as a clinical trialist. It was challenging to take trials to these communities because we couldn't, the privacy for data. I think I mentioned in our prep, I learned there are over 450 or 500 different countries within the United States in terms of sovereignty of data. So,
and we all have data sharing agreements.
That's a lot.
Yes, so you have a data sharing agreement and template so that if you're working with the Lumbees or the Goharies or the Cherokee in our state, what data does the tribe own? What data does the research companies and the big farms own? How do we share the data? How do we control? And then how do people who've owned the data, who've shared the data, actually work throughout the research process, even with beginning with the research question, because there can be a bias in the research question itself, and then which variables we choose to collect data on and interpret that.
So maybe with that, I think we're at time. No, it's okay. It's good. I opened for us to ask questions. That was an unplanned question.
Yeah.
But maybe let's pause now and open to the audience for questions. Maybe if you can come up with the mic, state your name and affiliation. I think I see a first hand right here.
Donald Alcindor Harry Medical College. My question is dissemination and cultural competencies. It's something we tend not to talk about. But when you go up in a community and you're talking to a mother and you say the word cervix and she's never heard that word ever in her life, and you ask yourself, you know what? You're not giving her what she needs because you're not telling her what she understands. You see what I'm saying? And the other thing is dissemination of information. When dissemination of information means that you're going to publish it in a scientific journal, how many people in that community is going to pick up that scientific article, read it, and understand it? Dissemination is something very different, and I think you have to be very clear. And I think you have to meet people where they are with them in front of you, just like we are here today, and disseminate that in a stepwise fashion so they understand where the data came from, what does it mean to them, and how important it is for this data to change their lives in some way. Because when you told them to join this clinical trial, you told them that all of those good things that would happen. They're waiting to see that.
I could say from a Bayer perspective, we've implemented lay summaries. So when a publication goes out to a scientific community, there's also and it goes back to the patients. It doesn't go into a catalog, a journal. It's actually sent to the patients. It's a thank you letter, and these are the results of what you actually participated. It's in lay terms, and we have our publication group work on that for that reason, so that they understand what impact their participation had in our trial.
Jude, could I just react to that real quick, because amen. You talked about we move at the speed of trust, and what leads to trust? Transparency. But how do you get to transparency unless there is good communication and understanding in both directions? And again, I'll put in one more plug for our True Group, because one of the practice areas that they've stood up is really focused on community-based research with a narrative research element. So how do you communicate? How do you tell the story? How do you, it's not about p-values. It's not about the scientific precision of the results of this trial. It's the so what and the now what. And so I just could not agree more. I think that notion of all the local context, whether it's the Lumbee context down in Pembroke or inner city situations or whatever, very impoverished people in Appalachia, understanding how to communicate in that local context and really describe things in a way that matters.
And that's what we mean by
receiver.
respect.
Yes, absolutely.
That's what we mean by respect, not using terms that we don't want people to understand.
Thank you.
Because if you don't do that, as you pointed out, you're not going to participate. And also, how do they want to give their data to you is another important piece that we haven't had a chance to talk about today.
Absolutely. I think that it was good. I was going to call you to close that question with that perspective, because you have experience. But I think I will go to the next question. But this is really an important question there, Donald. And I think we are all evolving as an ecosystem, supporting Janine from an Amgen perspective as well. We're literally moving now. We've started those lay summaries as well. But we're even moving beyond for the physicians themselves, even publishing that data in the reputable journal. How many physicians actually go to New England Journal of Medicine? So that's really the entire ecosystem. Communication, meeting people, each stakeholder, where do they get their information? And then how do we take that and develop newer ways that we can then break it down appropriately for the audience and pass that on. We're just starting that at Amgen. There's still a lot of room to grow. Next question.
And segue to another topic. I think communication is really important, especially when it comes to telling patients what they should be doing in order to advocate for their own healthcare. I think it's very confusing often to patients, and I'm going to touch on one example in particular. But first, I just want to thank Tim for his organization's work with regards to the Lancet Commission. There was a report that you put out on women, power, and cancer. I think it was one point in particular, that 2.3 million women die prematurely from cancer each year, and 1.5 million deaths, so most of them, right, could be prevented through basically prevention and early detection strategies. That report also found, regardless of geographic region or economic resources, women are more likely than men to lack knowledge and power to make informed decisions related to cancer. And I think in particular, we see this right now in breast cancer screening. I know I had this myself. Just out of curiosity, going back to your point, Cherry, about prevalence, and I'm going to come back to you, Tim, because I think you and RTI can help us. Going back to prevalence, how many women here have dense breasts? Please raise your hands. So this is a pretty significant issue. It affects 50% of women. It just means that we have more fibrotic tissue. And the problem is that dense breast tissue shows up as white on a mammogram, and so does cancer. So the mammograms, including 3D tomosynthesis women, if you're listening, we're being told that they work, but the studies are showing they're only marginally better. They miss 50% of cancers, and that's problematic because cancer found early is 100% treatable, breast cancer at least. If it's found late, there's only a 25% chance that a woman will be here in 5 years. We are told sort of amorphously, like ambiguously, maybe get supplemental screening, but insurance won't pay for it. So in the state of North Carolina, that's not the standard. 25 other states have actually adopted legislation to give women access to expanded screening. Not North Carolina, who's supposed to be a biotech hub. Part of the problem, because I've talked with the insurers, is that they're saying, well, the U.S. Preventive Services Task Force hasn't issued clear guidelines. But we all know that the task force is late. They always come sort of late, right, in issuing the guidance. And a lot of women, in the meanwhile, are not going to get proper treatment. We also know that a lot of people make money off of mammograms, right? There's the equipment makers, and mammograms are a big source of revenues for the hospitals. And so going back to your point, June, I don't mean to use this in that way, but profits often keep the status quo, and people don't get the best health care. In Europe, women get access to breast MRIs, ladies. We don't hear. That's socialized medicine. Canada, they're getting access, not North Carolina. We need to change it. North Carolina, just because we live here, we shouldn't get worse breast cancer screening. We should get the same. And I'm going back to you, Tim. We need help, finding an economic model to justify to the U.S. Preventive Services Task Force that women should get access to breast MRIs, contrast-enhanced mammography, or other means so we can find our breast cancer early. So I give you that challenge in your organization. I think there could be government funding with the new White House initiative. I really hope that somebody takes up the cause for all of us because we're waiting for somebody to do it. Thank you.
Well, I just want to say I appreciate that point, and I will tell you, to me, it also ties back to the power of story and the power of communication, because when policymakers, I'll never forget visiting with our government relations team to some of the North Carolina delegation, who, basically said to me, look, we love your reports, we love the data you give us, we love the statistics, but never forget the power of a great anecdote. And I think policy moves often, yes, based on, you want evidence-based decision-making and proof and the health economics modeling that we do that can show, even though this looks like a really high price to pay, if you look at the total cost of care that you're preventing, okay, I think we just have to get better at explaining that calculus a little bit as well.
They don't have calculus for Medicaid, but not for private insurance. So if you're on Medicaid, you get supplemental breast cancer screening, but not on private insurance. So the case has been made. We just have to make it more effective.
So maybe you close with a very key comment, the new White House initiative on women's research, right? When you were speaking, that's what I was anchoring towards a solutions approach. I'm also hopeful, waiting to hear. I think it was announced last week, the initial fund, $100 million. $100 million is a rounding error. Absolutely.
$1 billion goes to NIH.
I recognize that, and I agree, absolutely. And that's coming out of upper age. So there's hope that maybe there should be more. But I do agree with you. It's a good first step. I'm hoping we continue your advocacy and many others so we get more funding. Absolutely agree with you. So maybe there's a question here, and they would have one more this way. We're running out of time.
Does it work? Yep. Yeah. Salva Lesci, NMQF. So actually, I just want to bring a different perspective. There was a very important point, by the way, raised, which to me is one bias that we don't talk enough, which is the separation between clinical research and clinical care. Still, after like 20 years having worked on both sides, I don't understand myself why we separate that. And that goes also into the way you engage the community, right? There should be one conversation. In my mind, there is no kind of separation. I understand the, academic and so on, but the reality is you just need to figure out what would be the best option for you. In some cases, it's like access to a medicine that is approved. In some cases, being participation in clinical trial. So I would like to hear your perspective on that and also bring some example, right? We talk about release of summary reports, very important. We know sometimes, assuming the inclusion criteria allows that, and that we had some conversation this morning, people when they get in clinical trial, there are a lot of data that show their health automatically improve because they get checked more frequently, especially people from certain community get things that maybe they normally wouldn't do. But that part is somehow missed. Is missed even in the communication with the audience, that if you qualify and so on, your healthcare can get better and so on.
Yep.
And same issue, I use another example. Every company has patient assistance program, when you don't qualify for a drug. But even that is not talked so much in the context of this conversation.
Yep.
There are post-trial access program, where if you participate to a clinical trial and something works and you qualify, you can still get access to the drug. So to me, it's a one conversation to have about how your care gets better, and this has to happen at the community, and there is no reason for you have to do research in a place and then care in another place. If you really just decided that that's the model that we have to change. If we don't get over that bias, in my opinion, everything else is not working. I just like to hear your thoughts.
No, thank you. I think we're running out of time. We actually literally have 1 minute. And I think we could save the thoughts. Oh, we have a few more time, a few more minutes. That's great. Thank you. I appreciate that. That's a very key point. I think I may start, and then we could wrap it up, let's say in a couple of minutes, give the gentleman a chance. It's a key point you brought up, and it's something I've been looking at as well deeply, right? Clinical trials is a continuum of care, right? In some cases, it could be the beginning of care, right? But then where is that gap in the ecosystem? Reacting to your comment about the patient assistance programs, we function in a U.S. perspective, significant regulations. I used to say that once I look at the laws, I'm like, oh no, there's so many things we can know. So let's save that for another day, another time. But the issue of clinical trials as a continuum of care is an ecosystem challenge that my own reaction to that from a personal level, it starts at the medical school. How many physicians themselves actually, when I looked at it, that's where it starts. We were talking about trust. Have we done a poll to know how many physicians don't even believe in clinical trials? I have some in my family who do not. This is dinner conversations for us, right? They said they don't even trust it to tell their patients, right? So then how would they even? So I said I wanted to take a stab at that, and maybe we could pause there. We can follow up with this conversation on another day or in the hallway. It's a deep one that could really help the ecosystem. Your last question from you, sir.
Thank you. And I applaud the panel. Bill Lacey, I'm with the Association for Corporate Health Risk Management. I would expand your partnerships to include employers. We are the payers. And in rural and underserved markets, these are the smaller employers. Couple hundred employees to a couple thousand. We have a pilot going on in southern part of the state in Albemarle. It's a crisis across the country.
It is.
Lack of care, and it's because we have several middle people in between the employer, who's the payer, and the physician, who is the prescriber and the treater. We have a solution for all that, but it takes education. But you got to expand the partnership to include the employer voice.
Yes.
That's all I have to say.
You're in the
Great
record.
job otherwise.
Duly noted. You're in the
Thank
record. So we have time for one more?
You got about 4 minutes.
4 minutes. Any more questions? There's a question right here, please. One here. He's been raising his hand. I'm sorry. Go ahead, sir.
Make a comment.
Sorry, name and affiliation. Sorry for interrupting you.
Arina Anasakti from RTI with Tim. So I'll be careful, Tim, what I say.
Yeah.
I just want to make a comment about lay summaries and how clinical trial findings are communicated further downstream. We find a lot of disingenuous information being passed on, and one thing that comes to my mind straight away is to say that the drug is safe and tolerable, with no data to back up that claim that it is tolerable, because if something is tolerable, that information should come from the patient. And many cancer clinical trials, when it's done, they don't collect that information from the patient. But in papers, it's published that it is safe and tolerable. We recently looked at product websites of pharma companies, and we found many statements that were more than exaggeration. So there's a lot of work to be done when it comes to communicating information from clinical trials to lay public, let alone underserved patients.
Thank you for the
Thank
comment.
you. Sure.
Thank you. So there was one last one.
So this question is for Mrs. Beasley. Sorry, I'm Kim Doggett from Beijing and live here locally in the area. But my question was from you. Earlier on, you talked about how the campus of UNC Pembroke has no majority, which, oh my goodness, right? I'm already salivating. But what you also talked about the other, and this is a growing number around biracial or multiracial individuals. What would you say if you had to share with us, and I'm from pharma, how would you share with us how we should start to capture those other categories and maybe what some of those other categories actually are?
So, it's a great question. One of the things we do is are you a member of 2 or more races, and then ask which 2? Because a lot of the research forms just have, white, black, maybe, Hispanic, rarely American Indian or Native Indigenous. But a lot of people in the United States now are 2 or more races. And letting people self-identify, because then that gives you an understanding of their cultural heritage and what cultural backgrounds that they're using to determine their health. And so that would be one of my biggest points is are we asking, giving people an opportunity to say they're more than one? Because this thing of everybody fits in one box, that doesn't exist anymore really in our culture.
Thank you. I think to close that, I think even FDA released guidance not long ago, a couple of weeks or so, with actually including that new category for industry, of 2 or more. So that's actually, I think, is under public comment at the moment. But we also internally are revising our systems to capture even beyond.
And we do it in education. We do it in education.
So maybe this was a very engaging panel. Maybe can you join me and give an applause to these panelists? What a way to kick off the session.
All right, welcome back, everybody. Thank you so much for coming back. Please take your way to your seats. Welcome to Panel 2, Access, Choice, and Education, Representation in Clinical Trials. We all know that clinical trials are essential to advancing cancer treatment, and ensuring that clinical trials reflect the diversity of the patient population will improve safety and efficacy of future treatments. How can we work together to increase access, choice, and education in oncology clinical trials? With that, I'd like to welcome the panelists. Moderating this panel is Mary Liz Rich, President of the CEO Roundtable on Cancer. Our panelists today are Adrelia Allen, Executive Director of Clinical Trial Patient Diversity from Merck, Brian Frasca, Divisional President of the Midwest Region for the Brand Institute, Tara Frankel, Senior Vice President and Head of Oncology Development at Bayer, and Gary Puckrin, President and CEO of the National Minority Quality Forum. Thank you.
Thank you, audience, and thank you, John, for that introduction. We really do appreciate that. And I have to explain, he's not an outlier, and he's not an outcast. Dr. Brian Frasca will be, if he's not speaking, he might be coughing, but no worries, he is not contagious. But we did quarantine him to the podium, so he may actually have to step back and forth. But thank you, Dr. Frasca, for being so flexible and being out here. And it's kind of like you're at Family Feud or something. You're over there and you can even hit the button.
I love it. Hit the buzzers, guys. Hit the buzzers.
I call out.
And thank you, everybody, for the cough drops. And I apologize if I coughed on you at any point. So.
Great. So John certainly gave us the overview. And so we actually want to have a dialogue with the panelists up here today on how can we truly work together? How can we truly work together to increase the access, the choice, and the education and oncology clinical trials. And the best way to really get this started is for us to start with Dr. Tara Frankel of Bayer, because Dr. Frankel posed this question after our 2022 annual meeting and said, so what are we really going to do? So, Dr. Frankel, with that being said, what was the inspiration for sharing the effort around clinical trial access, which has now come to be known as the ACE cohort?
Yeah, thanks, Mary Liz. So I just say, I mean, I was inspired actually last year at the annual meeting that you had, and people were talking about it, right? It's a very hot topic since FDA is now requiring clinical trial diversity and inclusion as well. And there was so much passion about it, so much, I don't know, like just a desire to actually take care of this issue. But then you hear about it and everyone's doing this little piece and this little piece, and I was kind of missing, how is it all going to come together? How can we really, really make an impact together? And I shared this earlier, but like those people who know me, like I'm driven by healing. My whole life is like pharmacy, public health, doctor, and now trying to deliver new drugs for cancer patients, and so. Healing, teaming, because I know we can't do anything alone, actually, right? And drug development is like the perfect example of that. It's thousands and thousands and thousands of people, plus all the clinical trials and all the patients, the investigators it takes and the regulators, right, to bring a new drug to the market. And then the last part is delivering. Like I need something tangible at the end. I actually started my career in family practice, and I moved to surgery because like I didn't feel the delivery. And so that is really kind of what drove me to say, Mary Liz, what are we doing and how can we come together to tackle this problem? Because it's so, for me, we have all the expertise really that we need. And we had a little meeting right before this, right? Where you could see all the different perspectives coming together, all the things that we need to take into consideration. So I feel like we have it. We need to co-create these solutions together, and it's very solvable. Like we can do it. We just need to do it at scale. Like doing these little pilots, for me, is not really going to move the needle like we can if we want to, and we want to come together and kind of do it at scale. So somebody else at the meeting said, like, we just got to do it, and then we learn on the way, and that's exactly what I was thinking too. We do it at scale, to start with. We learn on the way. We tweak. I don't think we can go that wrong with all the expertise and the passion and the good intent that we have. And I think CEO Roundtable is the perfect partner to do it with, because you guys have so many diverse partners that hit all of these different aspects, and everybody has that passion and desire. So thank you for making it a reality, and then I think we'll drive it. It's going to become its own thing and drive itself.
Exactly. So just a real quick follow-on question to that. So what do you see as being, and actually Janine Calkins from the panel before in partnerships talked a little bit about this. What do you see as the most transformative, unique contribution that we could make towards this next phase?
Yeah, so I think my initial answer to that was really access. Like, how do we help establish sites? Because if we don't have those sites, then people can't participate. So that is just a necessary kind of starting point for me. And how do we get hundreds and hundreds of new sites out there in those in the diverse communities so people can participate? And I do still think that that's a necessary thing, but I also think it's going to be transformative because we have so much great input into it, but we do need to stay focused. There are so many things that were coming out of the meeting this morning and great, super important points, but we can also get really distracted and go on all these different tangents. So how do we kind of stay focused, have people do their do their thing, but also keep a running tab of what's everyone doing, and then how do we make that scale? Everything that everybody's doing should be thinking, how do we make this scalable? And then what's stopping us from doing that? What are those barriers? And then how can we attack those barriers together?
Great. So that's actually a great lead-in because you talk about the access. So Adrelia, you have my next question here. So as part of the ACE cohort, you're actually leading the community and education and really kind of some advocacy areas as well. Will you share with us some of the barriers that underrepresented communities and ethnic populations experience because of lack of participating in clinical trials?
Yes, so I think from my perspective, and I'll just add a tag along, in addition to building the research sites, we also have to spend quite a bit of time and focus on the communities. And, education is really going to be one of those key components that, our patients are going to have to understand and know what is a clinical trial. We have so much historical mistrust that are in communities of diverse patients where we really cannot move forward until we address that. And we saw that from COVID. The lack of diversity in clinical trials is not new. This is something we've been solving for a long time. But up until COVID, we've never had the opportunity to really sit down, listen, have listening tours, and even have the general public talking about clinical trials. So I will say it feels a little bit different today than years before, like we are not just talking, but really making some efforts, not getting us off of the hook. There's a lot of work that has to be done. And with the barriers that I'll say Black, Asian Americans, Alaska Native, American Indian, first of all, we have to deal with the trust. And that trust really, we can't ignore who they are just as a regular American and what they deal with on a daily basis of just being who they are. And so by who they are, and now we're going to now talk about health and talking to someone that doesn't look like them. And not to say that all healthcare practitioners can only be trustworthy if you look like the patient. Because trust has to be built. It takes time. It takes opportunities to show that you are consistent, that you are caring, and it's not transactional. And so personally for me, I'm a pharmacist by education, have been working at Merck for 25 years and in different roles in sales, clinical research associate, clinical research manager. But my father, he's passed now, but when he was diagnosed for prostate cancer, he was asked to take an MRI, but he refused, was not going to take the MRI because that was a trigger for him. And for me, as much education as his daughter had and someone that he trusted, he was not willing to do that. So it took a lot for me to convince my father that there were rules in place that protected patients, that it wouldn't be the same, and to really identify to him how his healthcare practitioners were treating him to show him that he could trust them. But he felt that he would be treated as a guinea pig. So I know from that experience, my personal own experience, and what it took to help my father to get over the hump to even consider to take that MRI. I can only imagine for someone who does not have someone in their village who can talk to them about the science, talk to them about what is a clinical trial. So we're really gonna have to take grassroots efforts to address trust before we do anything else. In the previous panel, there was a lot of discussion about social determinants of health, and we have to work together, pharma companies and even our policymakers, to help us address those barriers that we can't solve those. I know there is a legislation that's on the table that was introduced a couple of weeks ago on, the income exemption for patients participating in clinical trials. I mean, even we know, and especially for oncology, what that patient has to go through to participate, and to only be able to reimburse them $600. I mean, we couldn't even bring drugs to get them approved without patients, but we're saying you can only be compensated $600. We've got to do better. So, you know, again, so many different barriers, unconscious bias, you know, from patients, you know, just walking into the doctor's office, and because of who you are, you've already been judged on whether or not you would be a patient that would comply, would, you know, adhere to taking the medicine as required. So it's a lot of these barriers that we really have to come together to work on. Language, you know, how are we presenting and making the materials available for all patients to be able to understand, let alone the reading age, but is it available in their language, native language, where they can understand? So we have to really pull together. There's so many different barriers, but I'm really a believer that because it does feel different now, that with all of us sitting at the table, non-competitive space, as smart as we are, we can solve this solution.
Exactly. Absolutely. So I put a couple of notes down here. I want us to get back on the financial piece. So Dr. Allen, so thanks for bringing that up. And you know, whenever we were doing these deep dive sessions with each of the companies that really headed up the ACE cohort first teams around the table, the theme that you just brought up, trust. And that can be achieved through some communication, but also, as Gary has found, and you are all going into these communities, making sure that we are not getting community fatigue, right? Doing constant focus sessions, et cetera. So this is another piece that the ACE cohort will really help to streamline for communities to help travel faster, but gets back to that communication piece. I want to go over here to Dr. Frasca from the lectern over here. We're going to work this, okay? We're going to make it work for us. So, Brian, you're with Brand Institute. By the way, Brand Institute is a new member to the CEO Roundtable. Thank you. The access to healthcare model for the U.S. currently has in place can be complex and challenging for the average person to really, truly navigate. What are some, myself included, an average person, the average person to completely navigate? What are some ways in which the current system in place can be leveraged to help provide broader access to a patient population?
Sure, and I think Adrelia and I have spoken about this already. I think it's a lot about trust. And from our perspective, for those of you who don't know what Brand Institute does, if you take a look at the television, see any commercial where there's a drug name being promoted, we're probably the guys who named it. You can blame us if you can't pronounce it, but there are rules and regulations in place, I promise you. It is all about patient safety. So for us, a lot of times is getting past that patient safety element and having our patients and folks who are in our research trust us. And it's very simple for me from an access perspective. You've seen it with COVID. We've seen it in the LGBTQ community with PrEP, things like that. The community advocates, when they have the materials that are translated, that are simple to understand, and a lot of that can be accomplished, marketing, basic marketing. A lot of our clients name their clinical trials. They call them things like Elevate, Surmount. These are reassuring terms. They allow patients to trust and think, this is not going to be just an experiment on me. And I think we think about Tuskegee and all these historically terrible incidents, right? As a pharmacist myself for 25 years, you know, I really think working in the community, it's building that trust. It can be very simple. You ask anybody if they can draw the Nike logo. They can, right? So you think about that. Give a logo to your trial. Give a name, something very simple to show them that it's accessible, right? I think it's very easy, and that helps people navigate. When we think about clinical trials, there are so many things in place for the actual trial, but there's not when it comes to the branding and the marketing, all of that, except you can't be overly promotional. You can't call it the cure-all trial because it's not going to cure all. But you certainly can call it, like I said, very aspirational, very trustworthy things. And when we're thinking about oncology and cancer, these patients are Googling. The minute they find out they have a diagnosis, they're going to look things up. Why not have something that, you know, gives them information in an easy way? You know, we see a lot of our clients will, you know, do a nice brochure, things like that. I will tell you as a pharmacist, My first 2 years, I could not believe how many questions, how many body parts got shown to me, how many diagnoses I had to do. And you hear the pharmacists are a trusted profession. Well, we can overcome that. Pharma is here to help. We're not all big bad pharma, right? We are all in a room trying to help, and I think this is one of the ways that we can do that. Really bringing down access by allowing them to trust and see something relatable, right? But again, I think it does take a little bit of work. It doesn't take a lot of money, but it takes a little bit of work. You got to find out who your market is, something that we do every day, and be able to design something for them, by them, get the community involved in it, right? That's really what market research is. Let's spend those dollars and really just put it out there for the patient so they can understand themselves. I think that's an easy way.
Yeah, and I actually wrote down again pharmacy, so that's another takeaway. So we're going to come back to that.
Pharmacists are first. They get a lot of questions.
Brian, I had a thought earlier, like, is it something that we can do to have I'm going to say a promotional campaign, but that's not what I don't mean promotion for a product, but for clinical trials, period. Right? Not any individual one naming it, but what a great way to educate everyone.
Let's go US, right? We can work with the government agencies. We have, my colleague Todd is here, he's former FDA. He might not know where to go, but we could find out, I'm sure. But it's a huge, HHS is huge, but I'm sure you could find something where, how do we spend those dollars to promote that there are trials out there?
PSA.
A lot of these individual companies will promote themselves, right? But it's not done from a US perspective, right?
Yeah. Dr. Cochran, yes.
I'm going to lean in on that for half a second. We did an NMQ at National Minority Quality Forum. We did a program with pharma called I'm in which we were educating community and physicians about clinical trials. And one of the takeaways that I had from doing that program is that we actually need a national clinical trial registration day, where across our healthcare system, we're asking people to register for a clinical trial. I think of that as a pacing event in the sense that all of the patient advocacy groups and everyone begin to work towards that day, like Black History Month, Hispanic Heritage Month. It becomes a pacing event where you do a lot of learning and outreach before the actual event, and you educate the American public so that and you have a symbol so that it's almost like the Red Cross. People, when they see it, they understand what it is and what you're trying to communicate with them so that you actually don't have to use a lot of words at that point. So I would really put that on the table, that there's an opportunity to really educate the American public, particularly if the broad reaches of the industry comes together and says, here's our chance to help the American public understand the value of clinical trials.
Yeah, perfect.
Nice. So while you're actually on could you actually talk a little bit about the Cancer Stage Shifting Initiative?
Yeah, so I have to say, for me personally, this has become a labor of real love. So we worked with then Vice President Biden on the first cancer moonshot. And when he became president again, we signed up. And in doing that work, we came to feel that the White House didn't understand cancer as it was presenting in community. And so we did a listening session at the White House, bringing those who were either caregivers or had cancer, survived it, to talk about the experience of cancer in underserved community. My staff, who's smarter than I, decided that they should also bring EPA into that conversation. And what I learned, because quite frankly I wasn't focused on it, is that a significant percentage of Americans live in a carcinogenic environment by public policy. And if you think about it for half a second, talk about the industrial Midwest, for example, it left a lot of toxicity in the soil. We also built highways through minority communities, and so the air pollutants are running through. And in those industrial bases, we put housing. Once the factories left, we decided to put buildings on top of them. And the end result was people were getting exposed to carcinogens. But then when you went and looked, what you also saw is that in many of those communities, they were not getting access to best modern care. So you had this combination of exposure to carcinogens and the absence of care. And I'm talking in places like Rochester, New York, Cancer Alley in Louisiana, Fifth Ward in Houston, Flint, Michigan. I mean, they were all over, Milwaukee, they were all over the place, right? So we went back to the White House and said, with the CEO roundtable, we actually wrote a report. It said, if you're going to do the cancer moonshot, you have to go into those communities, because there's no way to reduce cancer mortalities by 50% if you haven't figured out how to deliver adequate care in those communities. And so the Cancer Stage Shifting Initiative is our demonstration project on how to go about doing that, because what we want to do is shift them from late stage diagnosis to early stage diagnosis of cancer. And it really has 3 arms to it. The first arm is the early detection arm. The science now has grown so that we can detect cancer before the patient is symptomatic at stage 1 and 2. And sometimes some of these devices, you can do multiple cancers at one time. And so in that early detection arm, what we want to do is we want to use it as a surveillance tool. We want to go into those high-risk communities where they have elevated risk for cancer and poor outcomes and say, let's understand the type of cancer and at what stage across the population is that cancer. Because what's also happening in those communities, they can't get into the current new clinical trials because those trials are looking for stage 1 and 2 patients, right? And so if they're all metastasized, they can't get in. And so by going into those communities and surveilling them, right, with these new tools, what our expectation is we can begin to find them at stage 1 and 2. But once you get the signal, then you got to get the confirmatory study, right? And so the second arm of the study is an interventional arm. And we're reaching out to the innovative drug companies and saying, partner with us, let's get those folks confirmed that from the signal that we picked up. And then if they indeed have cancer, let's get them into a clinical trial if that's the best appropriate thing. And if that's not best for them, let's get them best modern therapy. Not what they're getting right now, let's get them the cutting edge therapy. And then the final end of the trial is really the financial model, right? Because the reason why we decided, and it is the truth, is that we're rationing care in those communities. We, by public policy, have decided that we couldn't pay for everyone, and so we let poor people get exposed to the cancers and then metastasize out, and then write wonderful papers about how terrible it all is, right? And so we're saying, we don't believe that you can't pay for it, but let's go do the math. Let's do the math, find out what things cost, and then let's correct our public policy to make sure that we're providing. I'm a small d Democrat. I believe in our social contract. I believe we pledge to each other. And the first words in that Declaration of Independence is life. And when Thomas Jefferson wrote it, the first word before life was conservation of life. That's what we pledge to each other. And that's why we want to go back into these communities, because they're us. They're our family. And we don't have, it's a violation of our social contract, really, not to do that. And so I'm here and excited with the CEO Roundtable, and all of you in the room, you have different skills. Let's head to those communities and do a really big thing. Let's change cancer care in those communities, because we have the capabilities to do it. And so that's what the Cancer Stage Shifting Initiative is. It's about 21st century medicine. It's about taking control of situations that we can fix. And guess what? It'll bleed across society, right? Everybody will get the benefit of it. But we're going into that hardest place first, right? And taking care of those communities. And we want to do it with urgency, because when we go into those communities, it's gut-wrenching to hear the cancer stories of people who have cancer. I'm on Medicaid, and redetermination, so I'm now kicked off of my therapy. I mean, who does that? I mean, by public policy, you're going to take people who have cancer and kick them off, because guess what? their household income may have changed, or they forgot to write the paperwork up. I mean, that's not cool, right? I mean, that's not cool. So anyway, my point is, what we're trying to do is to say, let's build a very deep collaboration, because if we're going to meet the goals of the moonshot, that's the work at hand.
Great. So Gary was talking about a lot of barriers, obviously, and you know many of these barriers there. But Tara, from your work in the life sciences, and then through that lens, what have been some of the consistent barriers from life sciences that have kind of start creeping back in for us to be able to address what he's discussing here?
Yeah, I mean, this is a huge issue and really, really important. And I think from the life sciences perspective, like in terms of, if we're talking about doing clinical trials and things, in that type of environment, there's no clinical trial site, I'm absolutely sure, right?
Yeah.
And then one that actually kind of meets the capabilities of what we would expect, right, or pick to be a clinical trial site. So I know that, again, Janine's group is working on efforts where we're trying to build those site capabilities, really understand, like, if there is a hub of patients, we can map to it, and then how do we establish a site or help a site that's already trying to, what do they need to be successful? So that's one of the things we're doing, but there's a lot more, right, that we need to do in terms of identifying education. I mean, everything that we've been talking about. And I think one of the things that we can do as pharma is really kind of embrace this, this movement towards pragmatic trials. It's like when you were talking, actually, what was coming across to me is not just education, like us educating them, right? But it's we need to be educated on how do we fit into other people's lives, and how do we make a clinical trial accessible, like to them, not just by having it there, but also that they can actually come, right, and make it work. So the education is everywhere, from the PIs to the patients to us, to the community, like it's everywhere. So we're working on all these things, but it's a little overwhelming, actually, when you think about like all the stuff that we need to do. And so that's why I feel like we need to focus and do like what we can, but then continue to expand and build.
Well, and what you've been describing too is that, you know, the clinical trial access, I think it's been positioned largely that it's a life science equation that you have to solve. It's not.
We can't.
It's an ecosystem.
Yeah. Right.
It's the government. It's academia. It's life sciences. It's health retail. It's every health systems. It's every component of our social media. I mean, all of these channels help to solve the equation. And so by us bringing these different spaces together, we're going to get there faster.
Yes.
Versus trying to solve it in a silo of life sciences, or solve it in a health system silo, or a government silo, and so on. So, Dr. Allen, you've actually talked a lot about, of course, the barriers too, but how are some of the ways that we can address them today to really improve the diversity? And we've kind of, we've already talked about it some, but just kind of bring it back to the center of the space.
Yep. So many of you are aware of the diversity action plans that are required. We're waiting on the finalization, but we're in industry now preparing diversity action plans on how we are going to share with the FDA what is our strategy, what are our tactics that we're going to employ to have a representative patient population in our trials. And so in section 4 of that document really, requires us to be thoughtful and realistic about what it is that we're going to implement. It's one thing to write a plan, but it's another thing to execute and implement on that plan. And so some of the tactics that we've employed in, we talk a lot about where the sites are located, the infrastructure, and site selection, but we've really shifted to really thinking about patient selection. So the research site really should be located based on the patient selection for that trial, the epidemiology, the prevalence of the patients that have it, and we're driving our research sites in those communities. And so changing that model and mapping out where the patients are and identifying where sites are is a key component of how we're going to be able to change these barriers and really ensure that we have the right patients in the trials. In addition to how are we addressing those social determinants of health? How are we removing the barriers for patients to be able to say, yes, I am interested to participate? So specifically in oncology, what we've focused on is how can we make that patient whole? I talked about the financial barriers earlier with the income. So we've really looked at ensuring that for oncology trials, there are patient stipends and reimbursements. Because we know for reimbursements, that means the patient already has to have the money, and then we're going to give them their money back, but recognizing that some patients don't have the money to give, and really need to have some methods where they don't have to come out of pocket. So for transportation, we do have an enterprise-wide contract with Greenfire to provide ride share for across the country, actually across the globe, for patients to be able to gain transportation for the clinical trial. In addition, we're also, because we know it's in communities where patients are, learning about clinical trials. And I think from my goal and my role really is to make sure that for any patient, they have access to the information. And they can make their own decision whether or not to participate, but we've made it, available. And it's not such a mystery, which it is right now, of what is a clinical trial, where do I get the information, but working in communities. So for our sites that we offer them to supplement their staff in providing them research navigators, where those research navigators are working in communities and with the research site to be that liaison to help a patient understand if they've been diagnosed with cancer, they're helping them through that continuum of how to navigate getting to a trial, where's the information, how do I, even the academic institution, how do I navigate this large institution to get the care that I need? So different areas of removing those barriers and making sure that the patients have access to the clinical trial. And my last thing that I'll say is, by removing these barriers, I think we really have to be honest with ourselves and really spending a lot of time on that site selection piece and building infrastructure in these communities. Because if we take a look in this room, I know for some of the trials that we've seen, there are more people in this room than there are African Americans or even Hispanic patients that are in our oncology clinical trials. And until we help patients to be able, for oncology, be able to, standard of care, they don't have insurance, so how are they going to access? Now that's something that Merck cannot do. Any of my pharma companies, we can't make them whole, but that's something we do still need help with in policy to address that. So it's a complicated situation, but there are some things that we can do and we are working on those. But again, I'll still say until we all sit down at the table in a non-competitive space and be able to share back and forward, what is working, how are you doing this, so that we can make it accessible for all patients, we're still going to be lopsided. Right. Mm-hmm. Yeah.
Dr. Cochran.
One of the reasons why we decided to set up these demonstration sites around the country, and hopefully we'll have 10 of them by 2025, is because we see them as laboratories. Because the problem is so complex and requires so many different skill sets and capabilities, and also would tax even the biggest of the pharma companies to do on their own. If we can create an environment where we all can learn, and begin to understand some of the barriers and how do we overcome them. I think that's the point of the collaboration, right? Is to, because the best way to learn is to do. And so you got to go into these really difficult communities. I don't know if any of you have been in Flint, Michigan, or Selma, Alabama. I mean, it looks like you went to 1950, and I'm telling you, that's what it looks like. It looks like everybody with any money left is what it looks like. And so you're going into these communities. I think Flint, Michigan is one of the poorest communities in the United States, right? And so you want to set up an advanced clinical trial. Think about that. You want to bring 21st century medicine into a place that's really still in the 1950s, for all intents and purposes. And so we have to learn how to do that together. We have to learn how to do it respectfully for the community, because I can't tell you how many games get played in those communities where people have used their suffering to make a living. And they're deeply sensitive of that. So you got to go in and you got to be respectful. And you know, Flint, Michigan has a hospital. I don't know what's in there, but we should go in and take a look and say, so how can we stand up a clinical trial in this community, or do decentralize it? I don't know, because there's Detroit. I mean, there's some way to figure it out. Whatever. We've been talking to Michigan Medicaid, and they said to us, well, you know, we could possibly get some legislation that would support the study. And so all of us, we got a lot of government affairs people running around here. Let's go figure out what we need to do to stand that up. My point is, when we started writing, and I got a dear friend here, Darryl Robbins, who I'm sure everybody should get to know. He's doing some wonderful work. He looked at me and said, oh, you're about to boil the ocean. And I said, yeah, we're about to boil the ocean. Because the only way you can do it is to boil the ocean. Right? I'm sorry, you got to boil it. Because we've got to put new systems in place. This is a deep systems problem, and you can't do little pieces of it. You got to do the whole thing. And the only way you can do the whole thing simultaneously is all of us have got to do it together.
One more component I wanted to bring up is also, you know, we have to diversify the clinical trial workforce. We've got to do a better job in, you know, making clinical trial as a career choice more available to everyone. So one of our initiatives is, you know, working with ACRP to provide certification to community college and high school students, where they can take a certification and take the class, take the certification, and then be mentored. And ultimately, the goal was to help them to prepare their resume and to be hired at a clinical research site. So we was successful in taking a full scope of that for one of the students. But we've got to do that and replicate it, you know, 100,000 times over, so that we can definitely make it more common, you know, that clinical research is an option as a career and as participation in a trial.
Fantastic. So we're going to get to Q&A, but I do have one more question for Brian, since his coughing has subsided. I'm not trying to jinx you or anything like that. No pressure.
I did want to comment on what Gary and Adrelia were saying. I think, you know, we talk so much. It's a very smart room here. We've got a lot of initials after our names. I think we forget low healthcare literacy plays a big part of getting into the community, and this community piece is that piece that we need to bridge us to them, right? So.
That actually kind of dovetails into the model question, because I was going to ask you about, do you have any examples or models that could be that show where pharma solutions were brought directly to the communities to help access?
This is a loaded question. We talked about this in DC a little bit. So for me, one of the things I saw, not only was COVID, we all wanted to get involved with COVID, right? Because we were tired of sitting at home and being locked in. And I think that really motivated people. A lot of my research, or when I was doing my clinical rotations and things like that, was in infectious disease. So to me, watching where we were at in the late 90s, when I was graduating college in the year 2000, to seeing what we have now to treat HIV is insane. My father's also a pharmacist. He's 80 now. He tells me all the time, we didn't have half the drugs that you have now, you know? So thinking about that and thinking of that model, the LGBT community was very involved in those decisions. So I'm sure we've all heard of Gilead and PrEP, prophylaxis treatment. Prophylaxis treatment was born from hospitals where, you know, folks like us were getting needle sticks, and you had to be able to be, you know, treat that if you were going to, you know, deal with a patient population that had HIV. And watching them adopt PrEP, you know, and within the community, there's so much diversity in the LGBT community, you know, gay, lesbian, transgender, all of that, they all came together. To me, that's a perfect model. This is cancer. We're all affected by it. Right? I think everybody in this room probably knows somebody. So to me, you know, this smaller group really made a choice to be active. And yes, it's about sexual health, so maybe that was a little bit of an easier choice, but I still think it's a model we could follow. I mean, I think when you see some of the advances that they've had, and it was really simple things. They brought a really great campaign to a community with folks that were excited to talk about it, you know, and they could relate. You could relate. Okay. And it was all, like, I hate to say, but it was a lot of marketing, really good marketing. It's a great product, but also, you know, there's marketing behind it. And it was a very simple spend, and they just let people talk in the community. So you trusted them, you know? Really easy adoption, I thought.
So you guys ready for some questions from our audience? We got some in the back over here. Actually, let's get right over here first, so Jonathan's not sprinting left to right, so. He did it anyway, he sprinted.
Good afternoon. My name is Marla Dickerson. I'm Vice Chancellor at Southern University Law Center. I wrote down some notes because I had a couple things to ask. I'm in the middle of Cancer Alley. I am actually a product of a community that was bought out by a chemical company because we lived right across the ditch from a chemical company that's situated. When it comes to healthcare access in Cancer Alley, of course, the majority of those communities don't have access to health there in rural communities. And so at Southern University, our nursing school has a bus that goes out and tests for high blood pressure and diabetes, things of that nature, but we don't have a lot of cancer screenings that come out. So how could we partner as Southern University with Mark or with someone to come out, not to just have a one-off cancer screening test, but something that's sustainable for people who don't have insurance or don't have access to medical care? That's the first question. The next thing is the certification. We've partnered with companies in the past for tech and computer technology and computer science and different things of that nature, even at the Law Center. So how can we get that certification program? Because one of the things that we're doing right now is trying to increase clinicians of diversity through a grant that we have with the Louisiana Department of Health. One of the things that we are trying to implement is kind of bring back candy stripers because the candy stripers no longer exist. And so that's a way that we can go into high schools to get students of color really interested in trying to go into the medical field. And so I think upskilling certifications is really a way in order to increase diversity and access to people who don't know about careers, of course, because we don't know what we don't know. Right. Because, you know, you say your father was a pharmacist. A lot of our parents aren't pharmacists or attorneys or have those backgrounds to help us understand exactly what type of career paths we have. So I would love to talk to each one of you, you know, have those questions answered. How can we create sustainable cancer screening in places like Cancer Alley that doesn't have access to health care? And then also, how can we help expand your certification program?
Can I start? So does your I'll start the second question. Does your university have any type of cooperative education program?
It's a law school.
It's a what?
Law school.
Law school, okay.
So I'm over innovation.
Okay.
Okay. So I touch a lot of things that you don't traditionally think of
Okay.
when it comes to law schools. So while, and one of the things about Southern University is we are the only historically black college university system in the country.
Right.
We have 5 campuses. So we touch all the major
Right.
cities in Louisiana. And so I'm able to partner with the other 4 campuses to really bring to life various programs.
Okay.
If they don't have the manpower or bandwidth, not that I have, but I'm okay with it.
Like,
Doing things to bring programs.
new things, yeah. So one of the university I went to in Boston has what's called a co-op program, which means you work for 6 months, and you have to choose your sites, and there were different options and different opportunities. You hear pharmacy, you think retail, you think hospital, right? I was exposed to Astra before it became AstraZeneca, if that tells you how old I am. So to me, that was a huge eye-opener, was having the opportunity to work in that program, whether it's like a work-study program or something like that. To me, once you put somebody who is passionate about something in a field, they're going to gravitate toward it. But not everybody's going to love everything, but that certainly was an eye-opener for me. Yes, my father was a pharmacist. I never thought I'd follow in his footsteps, but here I am, right? So, and the second question, I would think that for me, if you want to get buses and things like that, it's a similar type of a program. You have young professionals. Obviously, you're a law school, so it's a little bit harder for you to get healthcare folks. But how can you partner with screening companies, or even pharmaceutical companies or device companies that are making these tests? They still need lawyers, right? So how do you bring that in where maybe they get a co-op type program or something like that, where they can help bring some of these early tests to the market, as kind of early screenings and things like that. I think there's so much great science out there. I'm in the Midwest primarily. We have a huge company, Exact Sciences. They do Cologuard. They're always looking at, things like that. So, maybe that's what it is. You reach out to an industry partner. Yeah.
I'm going to tap everybody who's in this room to become a partner, so we can actually bring that, again, because it's access. I'm in Louisiana, which means that a lot of things aren't happening in Louisiana. So that means that I have to create partnerships with people from around the country in order to make sure that we have that access. And so when it comes to even cancer screenings, my cousin, I told this story earlier, at the lunch table, my cousin, who was a pediatrician, she went into the hospital, went to the doctor for a stomach pain. It ended up that she had cancer. Although they said that it was a gallbladder issue, they opened her up and then found cancer. She was dead 2 months later. So there's a problem with, and I don't know if it's because people have biases. We talked about how people thought about black people in pain, in the past. And, sometimes those biases trickle down. And so that's where increasing people, even though your doctor does not have to look like you, he has to understand where you live, your life and exactly where you're coming from. And so that's a part of training that all doctors need to go through, not just increasing clinicians who are people of color who have certain things, but we all need to understand that people are diverse when it comes to health. And so that's why I also think it's important to start these cancer screenings, but then also that leads to increase engagement with clinical trials. Because at the end of the day, if we aren't starting with the basic education of why we need to do something in order to make sure that people understand this, then we can't even get to, folks actually wanting to take part in clinical education, because we do have that historical context. And so I think that that's something that we have to do. So again, I'm gonna tap everybody in this room because
well, Louisiana is my territory, so look me up on LinkedIn. I encourage everybody as well.
Salvatore Lisi right there will help you get cancer screenings in cancer. That's exactly where we want to go. The science and technology is there. We love to partner with you to make sure that your community has access to those screenings. The science is there, it's impeccable, and I think there's a way for us to, and I think that's the point of this conversation, right? Is that, that's a doable thing.
So we have time for one more question, I believe.
Hello, my name is Star Love Robinson Russell. I'm from Livingstone College. I am the professor of health and wellness there. But probably more importantly, what drives me the most in my position and in life is I am a current breast cancer survivor and thriver. And so as a thriver, that means that I live with the disease every day. I just had treatment yesterday. I take 2 pills every day. I go to chemo every 3 weeks, and I've been in this for 10 years. 3 different diagnoses. And so there's a whole lot, but I'm going to bring this down really quick into 3. The first being what I spoke about earlier is my question for you all. In regard to the distrust based on the history that being at an HBCU, our students, some of them are learning for the very, very first time. And I may have mentioned some things to you all today that you had never heard. right? And I just mentioned 3 small parts of our history.
Yep.
Right? There is much, much, much more, right? I face it a lot as a Black woman with cancer because of what you just mentioned. And the pain that we go through, we carry different as African Americans, right? So I don't look like I feel most of the time. And we are not really allowed sometimes in the workforce, right? Because I'm the breadwinner of my family. I don't have the room to say, I don't feel good, I'm not coming, right? So I put it on. You know, I was even in a position before where they thought I was lying. They thought I was in the principal. And I came to work dressed in my heels and doing my job every day. And it wasn't until they saw the markers on my chest that they believed that I had cancer. My colleagues were telling everybody I was lying. So, and it again, that's so true, right? So when I am standing in front of my students, and I get their attention right off when I tell them, when I'm there in my health class and I say that I'm an active cancer patient and I have been for 10 years. They're like, what? Right? But when I then also am telling them some of the difficulties that I have had as a patient, being a Black woman in America, in the health field, right? With having insurance, knowledge, I advocate for myself, so when I walk in my doctor's office, now they call me the troublemaker. But that doesn't feel good, okay? Makes me want to walk out,
Yep.
right? How do I talk to my students with all of this distrust, right? Based on our history and what we see happening in our own families that go to the doctor, right? When we come home and say, this is what they said to us, I'm not going back. Right? How do I say to them, I need you to go out and get our people in our neighborhood, because all of our HBCUs are housed in neighborhoods because we couldn't be anywhere else. Right? These are institutions that were in place because we could not be educated as Black people anywhere else. But these HBCUs. And so how do I tell them? What do I say? Because what we try to tell them is that, but look, I'm here, right? We have a new, research center and institution on our campus. We have greenhouse on our campus. We're here, right? And we're doing the work that, and we pull up people on the internet that say, look, they look like you, and they're sitting at the table and they're representing you. And then they hit us with, but look, there's 300 of them and there's one of us.
So
they come right back with that. And so how do I tell them? What can I tell them? How do I get them to understand how important it is for them to keep fighting and staying in it? But how do I get them to then, if they don't believe it, if they don't trust, and I don't have enough representation, I don't have enough proof to show them that we are making a difference and we do have a voice, how do I get them?
I just want to say you're already doing it. Yeah. You are doing it. I mean, I am empowered just by you sharing your story right now. I can't even imagine a student not even really believing you because you're so close to them and recognizing your journey and what you've gone through. But my message to my family is you have to be able to take care of yourself regardless. You are your greatest advocate to be able to speak for yourself. You know your body. And when you're in the doctor's office and they're saying, no, that's not what happened, you go to another doctor. And you have to keep going till you find the doctor that hears you, but you don't silence what you know about who you are and your body. So I think you continue with your message and sharing your journey of what you're doing, and they will come. I do recognize we have to do a better job also of being visible. I speak at my church and make sure that they know who I am, what I do. Before COVID, nobody recognized what I did, but now, because of clinical trials, it's more common. They can understand, have a better appreciation for it, but we have to continue talking. We have to continue being present and showing up in our communities, in our villages, so that they will model, and when they're in that moment, they will model what you've done for them. I was speaking to a patient, a prostate cancer patient on Monday. He's been in remission for 13 years, stage 4. And he made the point that, Adrelia, I don't care if at the time, before I was diagnosed, even if you were in front of me talking about a clinical trial, I wouldn't have paid any attention to you. It wasn't until I was diagnosed and in pain for so long that I became a student of my disease. And so sometimes we do have to recognize it's not until in that moment where people will, really harness in. But what we want to do is to educate them before, so when they're in that moment, it's not such a crisis of what do I do? Where do I go? If they don't know, someone in their village will be able to help them through that process and carry them through. But you continue doing what you're doing.
Thank you. So I'm like my sister over there from Louisiana. I am also advocating too for all of your assistance in regard to that. As far as you all know what you're doing and what's out there that we all don't always have access to or know about. And as far as the representation that can then come to my campus for my students to see would be amazing. Even virtually. It's 2024. I was in a Waymo in Arizona. So yes, we can go virtual.
When you get labeled a troublemaker, I have had that moniker many times in my life. I've been fortunate to find the CEO of our company, Jim DeTore. He has put a lot of faith in me and allowed me to be a troublemaker, and it has allowed me to grow as a person. So don't ever, it's hard to say it to you now, but sometimes don't worry about what people say. I think I was always challenged by the troublemakers because it made me learn, it made me figure out how I was going to talk to them better, how to educate myself better. So bravo for being a troublemaker. That's my opinion.
So I am trying to become most valuable moderator, and I'm not doing a great job. So I'm going to actually need to cut us off at this point. But we have a break coming up. Not right now. Don't leave your seats yet. But the panel has been terrific. So thank you so much for really bringing your insight and really your solutions. We're all in this together. So we really look forward to the work forward out of this. It's a calibration. We're doing some real-life calibration, real-time calibration at the same time. But again, thank you so much. Following this panel, stay in your seats. The SAS team will be joining us on stage to provide you with SAS Health details, and you won't want to miss it. So thank you.
Thank you.
Thank you.
Really good. You are the most valuable moderator. Okay, I'll give you guys a minute to kind of settle back in. I promise you there's a break in just a little bit, so you'll get some time out of your seat. My name is Gail Stevens, and I am the Vice President of Healthcare and Life Sciences here at SAS. So I actually have a group of people that focus in on these industries, both from a consultative way with our customers, as well as with R&D to create solutions that we hope will help the companies that all of you guys work for or serve. So our mission in life is to deliver trusted innovations that advance the entire health ecosystem with a faster, more productive AI and analytics platform. And with that in mind, first I just want to say, we're not doctors. Many of you in this room are the people that my mother wanted me to be. I did not turn into that. So because I'm not a doctor, doesn't mean I can't help doctors with the things that I can do. So that's where we kind of focus. We decided that there's a good strategy that you could have in a software company that would make the types of software that we have accessible to everybody and also a big help from many different fronts. And so what we're going to do today is we're going to kind of talk about the software that we have and what it can do for you, and then we're going to kind of wrap it up with sharing with you some things that we have done that are very much in the healthcare space that you can, I hope, can see that, that they would help you as well. So we have a platform that is built the way it is so that we can be flexible on either end. So we know that everybody here, and probably painfully aware, that we don't have standard data in healthcare. So there's a need to bring all kinds of different data into our system. So we have segregated out the data ingestion part of the platform so that you can plug in your favorite data in many different kinds and then bring them all together into a common data model. And then on the other side, you can then do analysis on the data that you have brought into your system. Hopefully you guys all know why that's important, and we'll give you some examples of what you can do with that here in a few minutes. But so that was our goal. And then we started to think maybe we should kind of modularize everything so that as you go through the different journeys that you have in your organizations, you can pick and choose the things that, I feel like I sound like a cellular telephone commercial. You can only buy what you need. So we're starting in that kind of a space now with many of the pharmaceutical companies in particular, where we actually have a clinical data repository that you can use that helps you to keep your data in order for all the regulatory purposes that you need it to be. But then we go to a different stage where you can then start to have your statistical compute environments and the other parts of your organization and the solutions that you might need in those other parts. So I'm not going to say a whole lot more than that because we have a good lineup here today to kind of give you more detailed information about all the different things that we do. So next on stage is going to be Steve Kearney. He's our Global Medical Director, and he's going to give you a little bit more information about our SAS Health platform.
All right. Hi, everyone. Great to be with you, and welcome to SAS again. It's very exciting. So, Gail was talking about all the brilliant scientists we have here and all the great work they do. I can't do any of that. But what I can do is say we have to get closer to the patient. We have to make it easier. We have to make it part of our workflow. We have to make it intuitive, right? And so the teams that I'm very fortunate to work with have been trying to do that. And sometimes, quite frankly, we have to work with things because they fail, right? So if you look at kind of across our portfolio and what this looks like in our analytics lifecycle, see, you're going to see an analytics lifecycle. You didn't know that, but you're at SAS. You have to. It's a rule, right? We really look at how did we bring in all of the partners and the entire ecosystem. That would be great since this is a partner summit, right? And then how do you overlay on top of that what you need, whether it's at the patient bedside, whether it's we have challenges within interoperability. So, you're sitting in North Carolina, the Health Information Exchange in North Carolina failed, had real struggles. And so SAS said, we'll help. Let us help you figure out what that looks like, right? So integrating data from 9 million people, right, is a challenge, right? But working with partners, we can do that. If we look across our entire industries, we should be learning from banking and retail and telecommunications, right? You all have in your hand a phone, and some of them taking pictures, right? We have to make it easier for them to access the data and to make decisions. So as we look across our portfolio, we also had to look at standards that Gail talked about. A common data model that would use common standards like the fire standard we talk about, OMOP, CDISC, everything that you guys are involved with, right? And then what does it look like if you're that close to the patient to have a validated environment that then would be at the edge, right? So we're working in all those spaces with our IoT teams. We learn from our fraud teams, right? Because our fraud teams have to figure out where people are. Wouldn't it be good if we knew where our patients were, right? So there's a great opportunity for us all to collaborate. That's really what I want you to get from my time. So we have brilliant scientists that work all across our campus. And what we like to say is that our people help you make decisions when it matters most. Well, I cannot think of a more important time than the folks who are sitting here on our stage that we're talking about being patients. And all of you, eventually, one day, whether you like it or not, we're all patients. We're all in this together. So we look forward to working with all of you. And now I'm actually going to turn it over to the person you really want to hear today. Because Palin Kay is a manager within our Advanced Applied Analytics Lab. And she actually does the models. She works on the hard problems that we're trying to solve for. Our teams work on how do you get it to you, right? And how do you make it easier to access it? And how do you make it low code, no code, open source, all the things we're talking about. She actually does the hard work. So I'm going to actually bring her out, let her share some examples with you, and I think it'll help for conversations as we go throughout the rest of the meeting. Great to have all of you here again. Look forward to talking with all of you. And now I will turn it over to Palin.
Thank you, Steve.
Yeah.
Hello, everyone. I am Palin Kay. Today, I'm very excited to share a couple of HLS applications that we have done at SAS using SAS Analytics. Before moving forward with the applications, I would like to start with SAS platform. SAS provides us end-to-end analytics lifecycle. It begins from the data management to the deployment of the models. And in between, we can use all different varied options of the advanced analytics tools, such as machine learning models, forecasting, mathematical optimization techniques, computer and machine vision, natural language processing. And also, of course, we are also using the visualization tools that we have that we can either use in the analysis part or representing the results from the models. And in today's session, I would like to share with you different use cases that we worked on. These are from different areas, different applications, and different advanced analytics tools available at SAS. And I will begin with the medical imaging. The first use case is from an academic SAS and from academia and SAS partnership. In this partnership, SAS joined forces with universities from Europe to improve outcomes in patients with colorectal cancer spread to the rebirth through advanced analytics. By identifying the precise locations of the liver and lesions within a CT scan, medical professionals can gain further insight into patients' response to treatment. Why is this important? Because this lesion segmentation task can be difficult due to the contrast and shape variability. And this is where SAS can be used and support the medical doctors to make their decisions. So before moving further, there are some details about the technical end. We are using biomedical image segmentation in this project. Segmentation is the process of partitioning an image into sets of pixels. Deep learning automates the segmentation process. This is where the advanced analytics components play a role as well. And in this project, volumetric assessment can indicate whether a patient is responding to a treatment or not. So the machine learning models will measure how much treatment is effective on the lesions so that we can see the reduction and make conclusions on top of that. In the image that you are seeing right now on the right-hand side, so we are seeing a CT scan, and then on the left-hand side, we see the segmentation from the CT scan, the organs available there. And in this project, we applied two-stage segmentation pipeline. In the first stage, when the CT scan is received, it first detects the liver. And then there's another segmentation step happening, which detects the lesions on that liver. And in the last stage, we use the visual analytics platform to visualize those lesions. In this video, you can see that this is the visual analytics platform available at SAS, representing those lesions from the images available. So this is a 3D image application and measures how much reduction happened based on the treatment. So I would like to also share another use case from medical imaging, and that was a partnership with University of Cambridge. In this use case, we are focusing on kidney transplantation. So in the kidney transplantation domain, so there are currently used existing measures to decide if a donated organ is showing the quality metrics is a good candidate to be transplanted for the recipients. As you can see here with the current statistics, especially the donor age can be a significant impact when they get older. The quality of the kidney can be in high risk. So in this study, Besides the existing statistical tools available, can we use an extra information to assess the quality of the kidney, of the donated kidneys? In this use case, so SAS and Cambridge Transplant Center worked together and implemented a computer vision model based on the biopsy images. Can we measure the health and the quality of the donated organ so that that can be used and transplanted for the recipients? In the solution potentials, it turned out that there can be 120 extra kidneys actually can be used with this new assessment on top of that what is available on the existing statistical tools. That's why that was a new way to look at using the available advanced analytics tools while the decision makers assess their decisions on these topics. Now I would like to move on into a different area, is precision medicine. And in this work, UNC and READY team had the partnership. So this work is originating from COVID-19. So as we passed through in this last couple of years, every COVID patients had different symptoms and different reactions for the COVID-19. So because of the different experiences and different treatment needed for each symptoms, there was a motivation in terms of can machine learning can help for the patients and help for the assessment in terms of can we categorize specific patients in specific categories such that they may need different treatments rather than just symptom-based treatment. In that work, we are following a phase approach. This is still a work in progress, so we are still working with the team on this project. But in this phase, in these phases, how we do is, first we explore the biological signatures indicative of severe COVID-19. And based on that, identifying molecular signatures of COVID-19 is playing a critical role to move forward in the machine learning process. And of course, evaluating the disease heterogeneity as well. In the following phase, we are also taking into consideration the electronic health records about the patients, and can they give us further insight about the characteristics of COVID symptoms and their reaction to COVID-19. And that will identify, that is basically based on identifying the EHR signatures of COVID-19 as well. In the personalized treatment phase, what we are envisioning is using all the available data and come up with a system, come up with a model such that that can tell us, can we use personalized medicine techniques instead of using a streamline or one way of approaching the patients. And in this methodological way, so we are receiving the data, processing and analyzing that. After that analysis phase, we are moving forward with the advanced analytics tools that we have available, which is in the machine learning toolbox in this use case, to train the models to come up with further insights. And we are asking the questions like, is COVID-19 a homogeneous disease or heterogeneous, which we know it's a heterogeneous disease right now, and which biological features are most indicative of a COVID-19 diagnosis, and can comparing EHR of patients with COVID-19 inform clinicians of differences in the pathophysiology. And how SAS contributes in this area is, SAS is a trusted partner to scale, so this platform enables us to scale and operate in large-scale data. We can deploy various advanced analytics capabilities, and in this use case, machine learning models and workflows. We have options of point-and-click interface so that we can interact with different backgrounded users for these analytical tools. We are leveraging existing systems and clinical trial gold standards, and we can easily operationalize those models. And now I am moving on with a different area in the health life sciences, which is in drug repurposing. And that work is, again, is a partnership with FDA. And this project is also coming, and motivation coming from COVID-19. Because as we all again experience as well, it was a very new viral disease that we didn't know so much about the symptoms and how it progressed, how to approach for the treatment. So in this area, discovering drugs already approved for at least one indication to fill existing unmet medical needs is the motivation to look and work on this topic. Drug repurposing helps to shorten time to market, lower drug development cost, validate safety for off-label users, which was one of the research at the very beginning of the COVID-19 pandemic, and discovering therapeutics for rare or new diseases. And central hypothesis and analytical methodology that is worked in this partnership was, there were two questions to begin with. Can similar drugs treat the same disease? Or can similar diseases be treated with the same drug? With those questions, the focus on that project is building models to discover similarities between drugs, diseases, and other biomedical entities so that we can answer those questions. And at the end, proposing the candidate drugs for repurposing. On the right-hand side, we can see the very high-level flow of how we approach that problem is, again, beginning with starting collecting, gathering the data for this problem, and then building on top of using those data, the models. Those models provide the outputs for the candidate drugs. And then we have using visualization tools again to gain the insight from the outputs, and if those results are acceptable to begin with, based on the outputs, based on subject matter experts' feedback, it can be rerun, retrain those models, and then till the results from the models are acceptable and more acceptable to move on the next stage. So in another perspective for this problem, we defined this as a needle in a haystack problem because there are thousands of drugs available out there. And we would like to have a process such that helps us to decrease the amount of drugs to be evaluated for the next stages. But of course, so for all HLS applications, always subject matter experts, doctors should be in the loop. So we are more considering analytics as augmenting the analytics component in the decision-making process. And in this case as well, subject matter experts is right in the center of the decision-making, and this is more as a results to evaluate from the models, but based on the, again, feedback from the models that needs to be refined and retrained till we get the results that are convincing to move on the next stage, in this case, for the clinical trial stage. And this is a sample screenshot from the visual analytics from this project that gives how drug relationships look like, how close they are or far away from each other based on the outputs, and also about how they classify those drugs, and more details available in here as well. But we always include some visualizations that helps and interprets us the results better. Now moving on to a different problem is a medical bookmarking. So still we are going to use machine learning models in this use case, but on top of that, there's some additional features as well. About this project, bookmarking helps doctors to find relevant information quicker. And medical history is very large, on average 1,400 pages. And manual bookmarking is very time intensive. So in that project, SAS help to the customer to automate bookmarking using the advanced analytics capabilities. So briefly in this project, on top of what is available at machine learning field, we also use text analytics that helps to summarize and gather the text together. In the flow of the right-hand side, so we receive, again, inputs, the documents available. We use text analytics to process all of them. On top of that, we implement the vision and template matching and the computer vision with deep learning to summarize that information as well. And then bookmark compilation is the last step for the outcomes from this process. And in the project value estimations are the decreased workforce costs and improving the consistency in the document review and greater completeness of the bookmarks. In the last area, of course not least, but I would like to move on the different area of the advanced analytics that we haven't covered before. This field, simulation operations research, is part of the prescriptive analytics. So I would like to go over very briefly about the projects that SAS involved in and SAS Analytics used to answer those questions. The first group is hospital staff scheduling. In this area, in that group of projects, we have two of them, evaluating alternative nurse staffing and scheduling policies in a NICU at Duke Children's Hospital. And the other one is modeling emergency department patient flow for a hospital in Western Canada. So now we are moving more in the operational level of applications and how analytics can answer those problems. In the other area is patient flow modeling. So again, it is more analysis-based simulation-based models such that patient flow for the Duke Hospital with limited and specialty bed capacity analysis and modeling ICU patient flow with bed and nurse assignment. And last use cases from the clinical trial enrollment, still using the simulation modeling to develop plans enrolling patients in clinical trials as fast and cost-effective as possible. That was for this given of time. I wanted to briefly and fastly go over those projects that we use SAS to answer those different problems that can come up in the health and life sciences area. Thank you very much for your time. Now it is time to hear from you. If you have any questions, I would like to invite Gail and Steve as well.
And Palin, thanks so much for that wonderful description. I will tell you guys, as we talk about the way you make this operational, the bookmarking, if you think about that for clinical trials, there's some real applications there. Matter of fact, initially we saved 80,000 hours. The beauty of it was, though, we got people's services faster, right? And providers were more satisfied and signed up for the program to actually get people enrolled in the services. So again, as we look at whether it's drug repurposing, any of the other work we're doing is how do you operationalize it, and it's built on the same technology platform. So that's the other important thing is once you're in that environment, you stay within that environment from everything from if you want it to be validated to if you want to be at the patient bedside. You know, one of the questions we had with like the drug repurposing, prior to that, we learned from the financial side. So the question they asked us real-time, operational, was, what's the impact of COVID for all Medicare Advantage patients in the entire U.S.? So think about what that calculation looks like and those real-time models look like in that. So learning from that type of big data, whether it's, you know, the entire Medicare Advantage population for the U.S., or the Ministry of Health for some of our Middle Eastern or Nordic countries, or India, where we're working right now with 600 million lives. So if you want to talk about scale, being able to work with those populations. So great work, very exciting. Yeah.
Yes.
Questions?
Again, Salvo Lesci and MQF. First of all, congratulations on the great work, and I like the fact that it's end-to-end and the partnership, everything about this. So I actually had one, I don't know if it's a comment, a reflection, a question, and then perhaps also a suggestion. So start with the comment. I think you guys, like others, are investing a lot in AI, machine learning. I truly believe, and I'm working in this space as well for other reasons, but that this is one of the greatest opportunity and the greatest threat for health disparity. Because I think greatest opportunity in a way you just illustrate can accelerate diagnosis, the technology is getting cheaper, combined with mobile, I mean, all the things that. But the greatest threat is you feed the machine the data, and if the data is biased to begin with, you just pretty much further increase the gap in health disparity, because now you're pretty much making assumptions that were wrong to begin with, just faster. So that's just a comment. I'm not telling you anything that is new, but that relates to then my question, and then perhaps a suggestion if you want. I'm very intrigued. I love the COVID study. I think it was the second one that you present, the case study. So then my question is, you are analyzing all this data. How much does data reflect the diversity of people that get COVID? That would be the question. The second thing that, and maybe is the reason why I asked that question, is because we at NMQF, we were able to do a study on COVID involving, for example, places in Louisiana. We were talking about how hard it is. I don't know where my colleagues are there. We had one of the most successful enrollment in Louisiana in the TESH clinics because of the engagement community. We were able to get 3,000 people enrolled over I think it was 1.5 years to screening COVID. We have all the data, we have all the EHR. We even have a biobank that we start analyzing. So that was more the proposal that if you are interested in enriching your data, your analysis, I'll be happy to talk to you. But those were 3 things that, sorry to throw all of that at you.
That's okay, thank you very much. And I would like to answer something about that.
Yeah.
I totally agree about everything starts with data. Without the quality of data, representative type of data, we can't conclude anything about those models. They will always miss the major part of the answers that we are looking for. These studies that we shared are the initial steps for the models, that we are showing the capabilities and can answer those questions to begin with. It's always having the researcher part within ourselves that can we really answer that question. But I totally agree with you. When it comes to operationalizing these models, we should start with the data that is representative, fair, and answers the questions for the larger use cases, larger scalability that we are looking at.
Yeah, and I will say also, we believe so much in this that we actually have a data ethics practice here at SAS. And our lead, Reggie Townsend, the vice president for that data ethics practice, sits on the president's task force for AI and has been instrumental in guiding what some of that work looks like. We also sit on the Coalition for Health AI, which includes all the partners that are out there, the industry partners that are looking at truly what does bias look like in AI and generative AI, traditional AI, that type of thing. In regard to the data set, we have a unique perspective for like the UNC data set because we can actually get data for all 9 million folks that live in North Carolina because of the Health Information Exchange. So when we talk about the way we apply it within the health system, we're unique in the UNC's health system is it's the state health system, right? So we do accept all uninsured, they do accept all, I say we, I used to be faculty there. They accept all uninsured recipients and are the state entity for that across the entire state. I will say when we go to other states, it is difficult, right? We do a tremendous amount of work in all the states in the U.S. and trying to find those populations that are underserved is one of the things that we really direct, like with our state and local teams. They do a tremendous amount of work in that space to try to find those folks and to get them into, and I used to actually practice at FQHCs, and so I have a heart for that kind of work. And we have teams that actually focus on that all the time. So we really do appreciate that. And again, it takes all the partners like you bringing that information in so that we can have access to that. Because if not, it's going to be based off of the data that's available. And we know that's not representative in most cases.
But we do also make an effort for our models to not have any embedded bias in them. That's part of why we have a data ethics practice at SAS, and that we spent, even before it was popular and all in the news, we've been doing that. So it's definitely forefront for us.
And spoiler alert, at this conference, we'll be actually announcing that in our software, it actually has model cards in a way that it's transparent, that you can look at not only SAS, but all the models out there in the health ecosystem. Yeah.
Please.
Yeah, so anytime you introduce a new technology, you have to talk about the limitations of that technology.
Sure.
Is that correct?
Yeah.
Of course.
And so the idea is that I'm going to go through some of the things you said, and I'm going to ask you what the limitations are. Okay. So let's start with COVID. Okay? Being able to determine those things about COVID for every patient. But can this technology extend to the point where it can identify those patients that are likely to develop long COVID? That makes it a very unique technology that goes a long way. Because when you look at COVID and you look at those number of people suffering from long COVID, it is substantial. And if that technology can cross that line, as we sit here today, there is no diagnostic for long COVID. So think about that. The other one is the lesions on the liver. Now, there are many technologies that can look at identifying lesions on the liver. That's clear. But the idea, can you go that one step further and be able to find micro lesions that are associated with metastatic disease? Can it do that? And what that means is that if you can identify micro lesions, then you will be able to take care of them doing whatever procedure you're doing, and this would limit tumor recurrence by being able to identify micro metastatic disease. And so that's something to think about as well. The other thing with the kidney, you said that you can screen those kidneys and find kidneys that normally would be thrown away. Is that right?
Yep.
Now, can you get kidneys that are at the brink of ischemic time? When I say ischemic time, I'm talking about that kidney that's been sitting around too long. Is it still useful? And how far in detection can your technology go to pull a kidney that has reached its ischemic time and may still be useful?
Can I?
Yeah.
Okay,
You
thank you.
address it, and I'm happy to
So,
as well.
Me too.
I totally get excited in terms of these are, how I am hearing is more about the next phases that we can look at. To start with the COVID-19 for the long term. So for all of them, I will say is starting with the data.
Right.
If for all these use cases that you shared right now, if we have a representative data or more than what we needed data is available, there is always a, I will say, optimistic to find those answers. Of course, without testing and implementing the current technology that we have, if we have any limitations to go further, or can we answer those hypotheses that you are shared with us right now? But my first go-to question will be is, do we have the data to answer all these questions?
You have COVID patients. So among those COVID patients, many of them that were hospitalized, they are going to have long COVID. Can you identify your patient cohort within the larger 9 million that have long COVID and those that don't? And comparative analysis using your technology to identify those patients that are likely to go on to develop long COVID.
We could. I mean, if we have all that data and we know what to look for, then we can definitely predict.
This would be important for a lot of people that are looking for diagnosis.
And we actually are used for those types of studies right now. So the difference in this, again, as we talk about technology, is it's human in the loop technology. So that technology also is only as good as the people that are using it, right? So for example, in the Nordics, we have the majority of the data because they actually do all the testing up front for all their patients. They don't do it the way we do here in the US, where you have episodic testing, right? Or there's a test that wasn't done because it wasn't part of that DRG or ICD-9 code. In the Nordics, they do all the testing up front, and then they decide what to do with their patient populations. So there's a big difference in our data set in the Nordics and our data set here in the US. So that's the technology, though, it doesn't matter, right? If there's a signal, there's a signal. So that's the important part of that. And then the pathology, we depend on the pathology vendors, all those vendors that then bring in the imaging as far as how granular that imaging is and how much work that Palin's team can actually do on it. But I will say that in the instances where we've implemented this, they've actually been able to say, based on their current protocols, they could not have used those kidneys. Based on the new data that they have, they're making different decisions.
I mean, it does evolve. And to be honest, I mean, I think I said this in the very beginning, we're not doctors.
Right.
So we rely on those partnerships with doctors and radiologists to help us get what we can out of the data that we get. So Palin's she's awesome when it comes to analyzing data, but she has to know what success looks like. She has to know what's good, what's bad, what she's looking for. She can't do it on her own, so she needs the doctor to help.
That's why we have all these partnerships, because they have the knowledge about what to look at, and we have the knowledge about how to implement the analytics, and we join our forces to have the final.
And that's why we think we need to democratize this. It can no longer be that you have all these, like there's only so many Palins, right?
Yeah.
Right?
We need more.
And so the easier we make this for you in the spaces that you work in to actually use these types of technologies and make decisions based on that and change the protocols, change the enrollees, change the tests that are done firsthand once the signal is identified, the better it will be and the better it trains that information. Yep.
There's it.
I think did we lose our?
Microphone available?
I can scream really loud.
Okay.
I just wanted to ask again about the repurposing and being from a pharmaceutical company. I'm very interested in maybe the therapeutic areas that you did find that were maybe duplicative, or if you can share some of the diseases maybe that you saw. Because again, in our world, you know, to use off-label use is kind of not a good thing, but at the same time, we'd probably like to know what we don't know. So could you share a little bit more about maybe the therapeutic areas at first?
So that partnership was more in the research angle in terms of, and based on the COVID-19. So we haven't gone further for the therapeutics part, and that was more in the first steps on that direction.
But the FDA actually has that technology that they're looking at drug repurposing, and their team's looking at the way they apply it separately from then what our teams are doing.
Yes.
And I hate to say it, but we have pretty much eaten into your break. Yeah. So they told me to tell you to come back at 4:10, and that's in 2 minutes. So I'm going to say come back at 4:15.
Yeah.
If you can,
yeah.
And we'll continue the program then. Thank you guys so much.
And Gail and I'll be around the whole time.
Yeah, and we're here, so if you want to ask us questions, we'll be here.
Yep.
Thank you very much.
Palin.
Thank you.